Okay. Let's see what we have today. The client is diabetic, and just a moment, guys. Okay, yeah. The client is diabetic and has a benign brain tumor. The client is scheduled for an elective brain surgery the next day, and the provider updated the orders, including keeping the client's nothing per off, nothing per mouth. Which of the orders should the nurse clarify with the provider? Discontinue insulin NPH subcutaneous and initiate sliding scale with regular insulin. Initiate 0.45% sodium chloride in dextrose 5 grams in water, IV 100 milliliters per hour. Discontinue dexamethasone 4 milligrams PO oral. Discontinue niacin 500 milligrams PO oral. What do you think could be the order to discuss?
B. A.
B as in boy.
B as in boy. Why? Oh, why do you think that is B as in boy? Do you think that B as in boy is something that is not beneficial for the client? What do you think? Say whatever you think. It's okay. We're here to study, to discuss. What is something that you don't like?
Because it's hypotonic solution.
Is a hypertonic solution. Okay, so is hypertonic. In reality, this is a combination of half normal saline with dextrose 5%. Is not necessarily hypertonic. But why in this client, this hypertonic solution in the patient going to surgery could be non-beneficial? What can produce this hypertonic solution in this patient that is going to surgery and is placed NPO?
Brain edema.
Brain edema is a possibility. So it's a good answer. Brain edema. Okay. Nevertheless, as I said before, in this solution, you are combining the osmolarity of the half normal saline with the osmolarity of the 5W. So you have two osmolarity added. So take care, because not necessarily it is a hypotonic solution. And this is a common indication, okay, in this kind of client, because it's covering the needs of electrolytes and hydration, and it's also covering the needs of dextrose or glucose to prevent hypoglycemia. Is there any other, so this could be a possible answer, because the risk, so let's make a quotation mark, risk of inducing brain edema in a patient that is going for surgery because of benign brain tumor. Yes, so that's why the rationale could be B. Is there any other indication that could be clarified for any reason in the opinion of one of you? Is the only one that looks indicated to be discussed? What about A? Discontinue the NPH insulin that the patient has been receiving, obviously, for a while, and then change to regular insulin by a sliding scale. Isn't it the same? Is indicated to do this change in a patient going to surgery?
Yes.
Yes, because
Yes.
diabetic patients usually need more insulin when
IV.
receive surgery.
When they are under stress. Okay.
Yes.
What is the risk, the biggest risk of a patient receiving insulin and going to surgery? Hyper or hypoglycemia?
Hypoglycemia.
So the biggest risk is hypoglycemia. So one of the main reasons of changing as a protocol the long or intermediate acting insulins, the same as the oral hypoglycemic medication to regular insulin, is because this way the risk of hypoglycemia during the surgery is decreased, because the patient will receive the amount of insulin needed as a regular IV, but depending of the regular or periodic capillary blood sugar that is measured. If you receive an standing dose of MPA, for example, that has a half-life of around 14 to 18 hours, no? 14 to 18 hours, and you go to surgery in this interval, and you are at risk under the anesthesia to develop hypoglycemia that could not be detected and could produce brain damage, no? And for that reason, nobody should go to surgery with an intermediate or long-acting insulin or with oral medication. So it's an important detail. So this order definitively is okay. So we rule out this option. And we have, I don't know what happened with this mouse today that is not obeying me. Okay. Okay, so we rule out this option, and it could be a possibility. B. What about discontinue dexamethasone 4 milligrams PO? What about this option? So it's an PO medication, and they order discontinue dexamethasone PO because the patient maybe is NPO. Is any problem? Hey guys, say
Yes.
yes, it is a problem. You say it is a problem, or you say yes, it is a correct order.
No se puede descontinuar bruscamente, ¿cierto?
Oh, somebody said in Spanish, something very interesting. That what kind of medication is this? The family, the group, is a medication for blood pressure. Is a medication an NSAID,
No,
an
es
antibiotic.
esteroide.
It's a glucocorticoid, also called asteroid. It's the family of the asteroid. Glucocorticoid, yeah, like prednisone, hydrocortisone, methylprednisolone, mometasone, betamethasone, etc., etc., etc. Yes. So, how you can recognize a glucocorticoid in a test? For example, I put mometasone. What is that? I never heard that. Okay, zone, yes? So sound familiar, zone. It's okay, your song. It's okay? So for the people that maybe are not getting the idea of this question, because these people that are connected are not identifying this medication as a glucocorticoid, yes? Is good advice from me to try to identify that a big, huge amount of glucocorticoids ends in on or zone. And I know that it sounds ridiculous, but it is a good trick to recognize a glucocorticoid. Yes? Okay. And you said glucocorticoids cannot be discontinued suddenly. Why glucocorticoids cannot be discontinued suddenly? Because can produce
Can have Addisonian crisis.
an Addisonian crisis, an acute adrenal insufficiency. So acute adrenal insufficiency, okay, adrenal crisis is something to fear in this patient that has been discontinued suddenly the dexamethasone, because it's true the patient is going to surgery and should not be taking, okay, a medication oral. Obviously, I don't know what does niacin for? Anybody know what is niacin? What is niacin?
B3, esa es la
Yes,
B3.
it's a vitamin. It's a vitamin B3, B3. For what is used niacin? For treating what? A part of vitamins deficiencies, which is very rare. For what? Okay, niacin at high doses is used for the treatment of hyperlipidemia for cholesterol. Okay, So you need to know that niacin, a vitamin of the group B, is the vitamin B3, is used at high doses to treat hyperlipidemia, lipids problems like high cholesterol, and has a big advantage. It can increase the good cholesterol, the high density lipoproteins, okay, associated cholesterol, which is good. Increasing HDL is good. And yes, this is niacin. So in reality, there is no risk of transiently for a while discontinuing these vitamins that are treated for long-term treatment of cholesterol. But this is, it is not important. So now we are left with the two. By the way, before moving on, because it could be a question in English, I saw this question in English. A person taking high doses of niacin for the treatment of high cholesterol can have any adverse effect that is common.
Flushing.
Flushing. Okay,
Flush.
so flushing. And flushing and pruritus is a common, very common side effect of taking this medication for cholesterol. Okay, this niacin, 500 milligrams. How can be avoided this flushing?
Aspirin.
On a baby aspirin.
Yes, aspirin, 1 hour, half an hour before the dose, taking a baby aspirin 1 hour, half an hour before the dose of niacin, you can avoid, can prevent this flushing. This is an Nclex question. This is a pharmacology Nclex question. I saw this question. Somebody commented me this question in Nclex. Okay, so now we are in our Nclex and we are remembering the stuff. We rule out a niacin because nobody is going to die if it stops taking niacin for a couple of days. And it's correct to discontinue the intermediate action insulin to prevent hypoglycemia during the surgery. And it's replaced by regular insulin, which is a shorter acting insulin, by a sliding scale, what means the patient will receive what is needed, is never receiving more than needed. Okay, so now we have two options that are possible. One solution is have a risk. Risk refers to future, no? Risk of favor the development of brain edema in this client, while the discontinuation of dexamethasone has a possible consequence an acute adrenal insufficiency. The acute adrenal insufficiency, also called as Addisonian crisis, is characterized by very low blood pressure. It's a shock. It's a very difficult to revert shock where the blood pressure is so low that the blood is not moving and appears a generalized ischemia in all the tissues and organs, okay? So what do you think is more important of these two options, the adrenal crisis or the risk of receiving quotation mark, okay, on
adrenal crisis.
So the adrenal crisis. So if we were in our Nclex after doing this analysis of the question, we should probably be, selecting this option as the one that need to be clarified, what kind of clarification how you communicate with the doctor you're concerned. For example, how you should tell me, suppose that I'm the prescriber, and how you tell me, okay, that you are concerned about this dexamethasone. Professor or doctor, I'm concerned that dexamethasone is a glucocorticoid and shouldn't be discontinued suddenly. We know that the patient is going to surgery. What could be the solution of this problem? I'm going to repeat, so trying to understand if a medication is taken orally and shouldn't be discontinued suddenly, and the patient must have this medication discontinued because need to be NPO. What could be the solution?
Intravenous.
Is this a yet? Can you say again?
intravenous?
Yes, move the medication for parenteral. Can be intravenous, intramucosal, etc. It could be one solution. Another question: if a patient has an oral medication and there is not parenteral alternative, and this medication this tablet is taken with a sip of water, how long before the surgery should be taken? Do you know how long should be stop the intake of clear liquids before surgery? How many hours?
2.
2 hours. The answer is 2 hours. 2 hours. Until 2 hours before surgery, we can take, okay, reasonable amount of clear liquids. And you need to know what is a clear liquid. Yes? A clear liquid. Is water a clear liquid? Yes. Can you take this dexamethasone, okay, 1 tablet, 2 hours before the surgery, okay, with a sip of water? Yes. A sip of water, a little amount of water. Yes, it is possible. It is another alternative. Yes. And the last question to discuss: what do you think about the dose? The patient has been receiving dexamethasone 4 milligrams, okay, PO, probably once or 2 or 3 times per day. We don't know that. It looks like it's once a day, probably for the management of brain edema, okay, to decrease the cytotoxic brain edema that can present patient with brain tumors. Okay, what about this dose? The patient is going to surgery. What do you expect with the dose? I suppose that you know that dexamethasone decreases the immunity, and that it could increase the risk of catching an infection. I assume that you know that dexamethasone, as all the glucocorticoids, inhibit the healing, the process of healing. So the migration of fibroblasts is decreased in the use of steroids, et cetera, et cetera. So what do you think about the dose? Should be decreased, or should be left the same, or should be increased?
Increase.
Increase.
Okay, so why should be increased?
For like
How you call the scenario in which you go to a surgery?
Psychological stress, ¿no?
No, psychological and physical.
No,
okay, they are going to cut you. They are going to take a knife and they are going to cut you. You understand? It's not only psychological. It's psychological and physical. And when a person, normal person, you and me, when we go through a psychological and or physiological stress, nature, God wanted us to produce more stress hormones because we need to develop extra strength to deal with this psychological and physiological stress. And doctors and nurses need to anticipate that this must be mimicked to protect the client from developing adrenal insufficiency. So the dose of glucocorticoids usually are increased in patients going to surgery. If they have been taking these glucocorticoids for a while, patient with lupus, patient with I don't know, asthma, or any patient that had been for any reason taking glucocorticoids before the surgery, you anticipate that once the medication could not be discontinued. Second, the medication dose should be increased. And third, you have two alternatives that to discuss with the provider. Is the provider the one need to decide? You have the alternative giving the oral medication at least 2 hours before the surgery, okay? With a sip of water, which is okay, like the blood pressure medication and many other medications that are taken orally before surgery, or to pass the medication to the parenteral via. So this is the way that you need to exhaust the options of this question. Any doubt? Those questions, these are topic that we just discussed is very important and is very high yield for Nclex. We are supposed to protect patients going to surgery and to be careful with this kind of mistakes or omissions that could put the patient's life at threat. Discontinuing the glucocorticoid could place the client's life at risk because, as we said, all the way around, we expect to increase the dose of the medication. Doctor will decide if it is parenteral or oral, but it must be increased. So this is the most important to take in consideration. It's clear, no? I had this question in my anchors. My anchors, I have, I don't remember if it was in the LPN or RN, but in one of my anchors, I had this question. Was a patient with lupus had been taking prednisone orally for a while and was going to surgery. And then the question was very simple, what you expect with the dose, okay? What you expect the dose will be changed, which should be discontinue, increase, decrease, or left the same. And of course, the answer is to increase because the patient is going to a physiological and psychological stress. Next question. How the nurse positions a client for an upper gastrointestinal endoscopy? Supine with head of bed elevated 30 to 45 degrees, flat left lateral, flat right lateral, flat supine. What do you think?
Reassemble.
Flat left lateral.
Okay, this is the correct answer. Remember that positioning is nursing business. We are supposed to know in which position the procedures are practiced. We're supposed to know in which position a colonoscopy is done or a bearing enema is done. We are supposed to know in which position a lumbar tap is done, a bone marrow biopsy is done, a thoracentesis is done, a paracentesis for decompression is done. Here we have another example. So please, when you go for your ankle, you prepare for your ankles, try to make like a list, like a flash card of positions in different procedures and in different scenarios. Positioning is nursing business. So it is supposed when the provider arrives for a procedure, we are supposed to know the position and the patient will be already in the position adequate for the procedure. And we need to explain before the procedure, the client, and we need to explain the client, okay, why the position, the importance of the position. The introduction of the endoscope for esophagus, stomach, and duodenum endoscopy is facilitated if the patient is in left lateral, flat left lateral. This position has two advantages. First, minimizes the risk of aspiration. You know that it is concordant with the recovery position, lateral position, in which a person, in case there is a regurgitation or there is a vomit, it minimizes the risk of aspiration. And second, the left lateral, the left dependent position facilitates the advance of the endoscope, okay, into the stomach, okay. So that's it. This is the right answer. What is the position for colonoscopy?
Left lateral position.
The same position, because it's the same position. Which lower extremity is going to be flexed, the right or the left?
The right.
The right. So you need to know in this case for colonoscopy, for enemas, for the introduction of suppository, we use the Sims position, which is a left lateral position with the right lower extremity flexed. Yes, very good. In which position is done the renal biopsy?
Right. No,
Can you repeat
cheekbone.
because I couldn't understand? The renal biopsy, in which position is done? The
From
doctor
position.
From position.
in prone position. Remember that the kidneys are in the back, okay? So the patient is going to be prone, okay? The patient is going to be prone, yeah? Prone, okay? And then doctor do the biopsy. But immediately after the biopsy, you are going to turn the client to the lateral position or to the supine position over the, with a pillow under the renal has been, biopsy. In which position we make, we place the client for liver biopsy?
Right. Right.
No, supine.
Supine.
Supine. The patient
Oh,
needs to
right
be
is after.
no. In which position you will place the client for a liver biopsy? Okay, so take care because in the Nclex they can ask in which position for or during the biopsy and or after the biopsy. So do you realize that you need to be aware of that? Huh? That you need to be careful in your test when if they ask you about the position, to pay attention what the question is asking. If the position is during, okay, to do the biopsy, yes, to do the biopsy, okay, or after the biopsy, the patient need to be in supine position with the right arm, the right upper extremity behind the head, behind the neck or up. Why? Because here is the area that the doctor is going to approach to do the biopsy. You understand? But immediately after the biopsy is when you place the client flat and you turn the client to the right lateral, yes, to the right lateral with a pillow under the area of the biopsy to also prevent the bleeding. So you understand that the reason for turning the patient over the organ that has the puncture is to make the own organ's pressure, make hemostasis, make pressure to prevent the bleeding. It's clear, no? So I assume by your silence that you are not asking questions because it's clear, because it's a thing cannot be forgiven, that you have doubt, you don't understand, and you keep quiet because you are shy or because you are afraid that somebody could listen that you have a doubt, which is one of the reasons that we are here, to clarify doubt. So is any doubt about this two biopsy position? Are we okay? Where is done the bone marrow biopsy more frequently?
Supine.
Right?
Supine.
Okay, where is taking the specimen of bone marrow in bone marrow biopsies?
The patient room, no?
Fine.
Okay, no, in which, let me reword the question. In which part of the body is taking the specimen of bone marrow in bone marrow
Isn't it
biopsy?
in your lumbar? Yeah.
No.
Isn't it your lumbar?
In hip.
Close to the hip.
I think you call this area.
Iliac Crest.
Do you know where is your iliac crest?
Yes, between lumbar 3 and lumbar 4.
No, I'm touching my iliac crest and I'm sitting in a chair. So I don't know if you were a cowboy, you were wearing your belt and the pistols, okay, above your iliac crest. I don't know if
It's in front, la pistola.
Okay, but first let's clarify what is the iliac crest. Have you seen this bone that I apologize because today I have a different mouse and I am having problem with my mouse here, okay? So I'm not in my usual office. Okay, have you seen this bone? Okay, this is oh my goodness, qué difícil. This is the vertebral column, the lumbar. This is the sacral, okay, the sacral. Do you know this here comes the femur? Okay, the femur. okay, the femur. Okay, here comes the femur. Okay, okay. And you know this bone, no? This bone you have here, yes? Okay, this is the iliac, bone, and this is the iliac crest. Are you good with that, or you don't understand my drawing?
Profe, isn't that your hip bone?
The hip is here, here. This is the hip, hip, hop. Hip is here, where the femur connects with the acetabulum of this bone that is the iliac bone. This is the hip. In reality, this is more the waist. Here is a little higher here, like here is the umbilicus, the navel, okay? So, Dios mío, can you touch your, okay, this, we need to use the anatomic terms. Maybe the late term of this area is the hips, but this is this bone that you can touch at each side, okay, at the level of your waist, okay? That is the iliac crest. Okay, this is the iliac crest, okay, iliac crest. So trying to recognize, trying to explore if you need it, okay, Google that or see that, what is the iliac crest, okay? It is prominent. Here in this part of the iliac crest, you have the anterior and superior iliac spine. And then here is the navel, okay? And then if you draw an imaginary line between the navel and the anterior and superior iliac spine, in the more than the middle, in reality, in the junction of the middle third and the distal third, you have the McBurney point. You know what is that, no? The McBurney point, yes, the appendicitis point. You know that?
Yes.
Okay, this is an Nclex question. This is an Nclex question, okay? And all this is the iliac crest.
Okay.
Yeah? Okay, so touch it. It's very easy to touch, okay? Okay, so now that you know that in which position, okay, you anticipate that the patient is placed for a bone marrow biopsy.
Fine.
Free. I heard free. I'm sorry, and you know that I have a problem hearing. You need to have patience with me. I'm an old person. Okay, probably you are not my student, but any student that know me, I'm a very old person. I have hearing problems. So I don't understand what you say. And when I say I don't understand, please repeat that. So I can't. You are going to be dealing with old patients mainly. So you need to be very patient with all people that cannot hear. Would you say free?
Supine.
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 No, it's lateral.
Lateral.
It's lateral.
Yes.
So you are going to put the iliac spine that the doctor, the iliac crest that the doctor wants to do the biopsy in the up position. That's it. Okay. So the patient is going to be comfortably, okay, and then the patient is going to do that. This bone marrow biopsy is with local anesthesia, doesn't require preparation, and is something that the patient can get up and use a Band-Aid and go, okay, to your house. Okay, let me see what other position can be tested. What is the position for a patient going for a thoracentesis?
Sitting position and leaning forward.
Exactly. It's sitting upright, and sitting upright, okay, can be a bedside, can be in the client's room, but should be resting comfortably in a solid, okay, surface. So maybe an over bed table, those tables that are used to put the foot to the clients. So you put the client sitting in the bed, okay, or in a chair, yeah, and it's resting the two arms in an overbed table, yes, and then this way the doctor has free the back of the client to enter, okay, and you know, remove the liquid, okay? There is no special position after the procedure except, okay, making the patient, you know, comfortable to breathe, elevation of the head of the bed after the procedure, as we usually do, you know. Okay, let's see which order. Okay,
Professor, I'm
why?
sorry.
Yes, go ahead.
You said that this last position for the thoracentesis, they have to be leaning forward, correct?
I don't agree with leaning forward. Okay, the
Just
patient should not be
standing
leaning
straight?
forward. A patient that is leaning forward, a patient that is leaning forward, okay, and drawing a patient leaning forward, okay, a patient that is leaning forward. The liquid, okay, let's see, that is the pleural cavity. The liquid will be displaced forward.
Oh,
The
that's
liquid
right.
will be displaced forward. You know what the liquids do with gravity, no? And the side of penetration is this. You understand? So I
So it's
have,
best to keep them straight.
I could bring a video of the procedure that I usually, when I used to teach on concept 2, I presented the video, and the person who was described the position in the video insisted that if the patient is leaning forward, which is this what I'm drawing here, the liquid will be displayed forward. And then, because the approach, the needle is going to be entering in the posterior and lateral space, then there is more possibility in this of piercing the lung, of piercing the lung that is here. Yes? So the patient should be upright. The answer is, the position is called upright sitting, upright sitting, okay, sitting, but with comfortably sitting upright, but with the two arms resting in a solid surface that could be an over bed table, okay? But the patient is sitting at the bed border or in a chair, and the doctor will approach for the biopsy here. Make sense?
Perfect sense. Thank you so much.
A question, because I just saw that recently in a question, okay? What happens when the liquid is removed? What the patient feels after the liquid is removed? Somebody knows? Somebody
Pain,
knows? Huh? What did you say? What did you say?
Relief?
pain,
The answer is pain. Be prepared. A patient before the procedure, okay, maybe was experiencing shortness of breath. Are we good? After the procedure, the patient would experience relief of the shortness of breath, but will appear pain. Are you understanding me? It's clear? The rationale is the following.
Yeah.
Before the procedure, the lung, let's see that we have the black stuff is the lung, the red stuff is the visceral pleura, and let me change the color. The blue stuff is, no, blue not, because I'm going to make the liquid. The green stuff is the parietal pleura, yes? But they are separated by what? By liquid. Yes, by liquid. Yes, by liquid. This liquid that is between the two layers of the pleura is pushing, okay, is compressing the lungs, and maybe the patient is experiencing shortness of breath. But when they remove the liquid, okay, the two inflamed, because why is liquid there? Because the pleural membranes are inflamed, are going to contact each other. I'm going to be in contact with each other. Why? Because the liquid that separated the two membranes had been removed. And because the two membranes are inflamed, yes, they are going to start rubbing one over the other, and it is going to produce a very intense pain. So this pain is not necessarily, okay, a sign of complication. Yeah, a sign of complication. But we should be careful to assess through auscultation and percussion to be sure, because the complication of this procedure is the collapse of the lung, no? Because accidentally could be pierced. And if the lung collapses, called pneumothorax, no? If the lung collapses, then the patient will have decreased, okay, sound, decreased vesicular sounds, hyperresonance and the percussion, deterioration of the respiration. The patient will develop, okay, respiratory distress, and the most important, as pressure builds up inside the pleural cavity, if pneumothorax is a complication, you see the deviation of the trachea toward the opposite side of the puncture, no? Because you're not building up of pressure, pushing the mediastinum to the opposite. And that's why it's a routine, it's a protocol in the majority of the facilities before and after the procedure to have an X-ray to verify that this complication has not happened, okay? So do you understand me that pain is expected, but also we need to be aware of the possibility of complication like the pneumothorax? So this is what makes, okay, sometimes difficult, because remember, doctors do the thoracentesis and say, nurse, take care of the patient. If you notice anything wrong, call me. So now you need to be knowledgeable of what kind of complication is going to happen. Usually doctors, and then you need to anticipate that, leave prescribed PRM pain medication because it's expected the pain, but if the doctor forgets it, you need to remind the doctor. Doctor, do you like to have some PRN pain medication prescribed just in case the patient has pain after the procedure? It's something to have in mind. The pain is expected. Pain is expected, and it's very constant, very, 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 very frequent. But the same way, we need to continue monitoring the patient for the possibility of complication like the pneumothorax. Okay, so now this is an idea that came to my mind because I'm very, 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 convinced. I'm very, very sure that many of you are going to have positioning, okay, question in English. Let me ask another position that I saw in English. If you have a patient with ascites, a patient with advanced cirrhosis, portal hypertension, and an important ascites, why doctors remove liquid from the abdominal cavity? Is to improve the jaundice, to improve the liver function, to decrease the portal hypertension, or why? Why they remove
Improve respiration, no?
to improve
Breathing.
respiration. See, it is exactly. This is very important to know that the reason for doing paracentesis in those clients, because those patients have so much pressure of the liquid built up inside the abdominal cavity that is pushing up the diaphragm, preventing the patient from breathing. So the patient is going to have this as a palliative procedure to improve the breathing. Okay, so now based in this knowledge, if they ask you in which position you place the client that is going for a paracentesis, and you say,
Sitting
okay,
position
in what?
and sitting position.
In a high
Polar.
exactly, high
High
power.
polar position.
As high as tolerated, because the patient is in respiratory distress. I saw somebody has this question in English, okay? Because the patient need to be supine, but need to have the head of the bed elevated, okay? And generally, the doctor is going to introduce the needle in the right side, okay? In the right lower quadrant, let's say quadrant of the appendix, okay? Don't forget that a classical question in many, many procedures, you need to ask clients to empty the bladder before the procedure. Not only in this, in any procedure. Do you imagine ladies, because the majority of the, excuse me, the gentleman that kindly, okay, talk to me when I ask the question, but the lady, do you imagine having a pap smear with a full bladder? Should be very uncomfortable, yes? Do you imagine having, I don't know, lumbar tap with full bladder? Okay, you know how horrible it is to be, experiencing the need of peeing. So don't forget that before, taking your client to the, to the examination table or bed, please take the client to the bathroom to pee, to empty the bladder. In the case of paracentesis, has another important reason, because the bladder is very near the site of the puncture, and you don't want the bladder to be accidentally punctured during the procedure. Okay, so have that in mind, because I remember that the question that the student had of the preparation of the client for paracentesis, positioning the client for paracentesis, was a place in order the steps to prepare the client for paracentesis. And the first was precisely take the client to the bathroom to emptying the bladder, which make an absolute sense. Okay, don't forget that for anything, even for an EKG, guys, please ask the client to empty the bladder before. It's very uncomfortable to be in an examination table with full bladder. Okay, you know that the exception for that is when an ultrasound, including a amniocentesis, is done in a woman that is not pregnant, or a woman that is pregnant with less than 20 weeks of gestation. The bladder need to be full to make a contrast, a sonographic contrast, to visualize the uterus and the stuff that is in the pelvis. But a part of this exception, we always ask the client to empty the bladder. Okay, so somebody remember any procedure that you read or study that we are forgetting that we could, check for positioning? So we talk about the biopsies. The most important is liver, renal, bone marrow biopsy. Okay, so the one that somebody mentioned you that was, in the lumbar area, is the lumbar tap. Okay, the lumbar tap. When a lumbar puncture is done, the ideal position to have the patient at the border of the bed, and then the doctor will access that in the lumbar area. Okay, but this is different from the iliac crest, from the bone marrow biopsy. I'm just trying to remember the question that I seen, positioning for procedures in echoes. Okay, let's move on. Which of the following recommendation is the most important to teach a client with Addison's disease? Increase consumption of dried fruits and vegetables. Limit salt intake to 1,800 milligrams per day. Practice yoga and meditation. Program 1 hour of aerobic exercises most days of the week. What do you think could be of these 4 recommendations the most appropriate, the most important for a patient that suffers of Addison disease?
As a cat?
Sí.
So everybody, but let me know something. It's not good to consume fruits and vegetables?
A for
Yes.
high
in potassium.
Yes.
Yeah.
Yes.
So it is very good. I consume a lot of dried fruits and vegetables, I personally, okay, because are high in potassium. So having a diet high in potassium is good for the patient with Addison disease. Do you agree?
No, it's bad.
No. Why is that?
Tiene potasio.
Okay.
Because she has hyperkalemia.
Okay. Are you saying that Addison disease clients have tendency to have hyperkalemia? Is this true?
Yes.
Yes.
Yes, it is true. So take care, guys. Take care. Remember that in Addison's disease, everything is low except the potassium that is high. Okay? The potassium is high, the heart rate, so there is tachycardia, heart rate is high, and the pigmentation is high. Okay? What is low in Addison disease? The aldosterone and the cortisol. What is low? Sodium and water. What is low? The blood pressure. What is low? The weight. They lose a lot of weight. What is low? The blood sugar. Yes, the blood sugar. Okay. The stamina is very low. The tolerance to the stress is very, very low. You understand? So put a client with Addison disease studying nursing school.
No.
No, obviously no. Do you understand what I'm saying? So the tolerance of the stress and the stamina is very low. But they have high the potassium. They have high the heart rate. Why they have high the heart rate? Because they have low blood pressure. Guys, the compensation of low blood pressure is tachycardia. So first, blood pressure goes down. Second, we compensate increasing heart rate because we activate the sympathetic nervous system, something that is very constant. That's why Addison disease, they have high heart rate. They have tachycardia, a compensatory tachycardia. It's the compensation of the hypertension. Guys, pay attention to this. Don't forget that because they make this question very, very, very frequent in main course. If you understand why a patient with Addison that has everything low, that high heart rate, is to compensate the hypertension. But don't forget that they become, bronze, how you call tan, like if you're working a tanning bed, they have this hyperpigmentation of the skin, of the gums, of the lines of the palms, any scar in their body become hyperpigmented. Something similar to happens, the lady should know that, okay, when a woman becomes pregnant, that that everything becomes hyperpigmented in pregnancy. Something similar happens in Addison disease. That's why in Addison, the trick, the mnemonic to remember what happens in Addison is everything is low except potassium, heart rate, and pigmentation that is high. Makes sense? It's like helping because sometimes in the test we are nervous and sometimes mnemonics can help us. So that's why increasing the intake of dry fruits and vegetables that are rich in potassium is not a good recommendation. And if we had, because we mentioned already that if at low sodium, you should not limit the salt intake. Is any other situation in which we nurses don't recommend reducing the intake of salt? Because in general, the population is good to recommend reducing the intake of sodium. But is there, and now we know that there are exceptions, like in any rule. Addison disease is one of the exceptions. Is any other exception that in which reducing the intake of sodium is no good?
And lithium medication.
Lithium intake. Okay. Okay, so don't forget that. Okay, so now Addison and lithium is not good to reduce the intake of sodium. I want to add another one that maybe you don't remember is cystic fibrosis. In cystic fibrosis, we'll have a condition in which salts are lost. It's lost. It's because they have a hyperfixation of fluoride in the sweat and other exocrine glands. In cystic fibrosis, I don't know if you remember, is an hereditary disease, autosomic recessive, that affects mainly the lungs, producing a progressive, deterioration of the lung function, and also produce an exocrine pancreatic insufficiency with steatorrhea, malabsorption, and we have children with lung problems, recurrent respiratory infections, very sticky, tenacious sputum that is difficult to remove, and this pancreatic insufficiency that requires the replacement of pancreatic enzyme through the pancreolipase, which is the artificial pancreatic enzyme. You remember the cystic fibrosis? Do you remember that there is a test, a sweat test? Okay, it's a sweat test that doctor could collect sweat, okay, from the client to determine the amount of chloride in the sweat. Okay, so this is cystic fibrosis. Okay, in this cystic fibrosis, we don't limit the intake of sodium chloride because there is a condition in which especially the chloride is lost in excess through the exocrine glands. Okay, so look at this. We have now three conditions to memorize in which there is an exception of the very healthy recommendation of the American Heart Association on the DASH diet. And DASH, you know that is in Spanish is pizca. It's just a little, yeah, just a little. Okay, it's just use just a dash of salt in your life, in your diet. Yes, diet aim to stop hypertension or diet aim to yes. So they recommend a very low consumption of sodium. Yes, but those are exception of the rule. Okay? Those are exception of the rule. So in the DASH diet, we reduce sodium and increase potassium. Okay, this is an exception here. It's a patient with Addison disease. Very good. So we already rule out these and rule out these. Good. And we are left between exercising, that is something I should be doing and I'm not doing. So I have guilt because I'm not doing this. I should be doing that, and I'm not doing that because I'm very lazy. And practicing yoga meditation. Why do you think that yoga meditation is better for an Addison client than exercising? Stress tolerance. Stress tolerance again, okay? They don't tolerate the stress. Physical exercising is a physical stress. If you are in good condition, of course, exercise is recommended. But if you have a disease that you have decreased tolerance, okay, tolerance to the stress, okay, and hypotension, and loss of weight, okay, it is not recommended to have, okay, this high level of exercising. So yoga and meditation will help the client to manage the normal life stress, and of course, it's a good recommendation. Everybody understood Addison disease and why this condition? Yeah? Are we good? Okay.
Yes.
If you have a patient
Yes.
with Addisonian crisis, in which the most dominant disbalance and symptom is the shock, the hypotension. Okay, what is the most important medication of a list of medications that are given? Glucose, isotonic fluid, parenteral hydrocortisone, rapid acting, okay, steroids, control of infections or any precipitant of the condition. Which one do you think is the most important of this one that I mentioned?
Hydrocortisone,
No.
normal saline.
Yes. So this is the priority. Why? Because the patient has hypovolemia, because they have, okay, they lose sodium and water, okay, because they don't have the cortisol. Yes, they lose, they are wasting the sodium and water, and then they have hypovolemia. And as a consequence of hypovolemia, they have the hypotension. So the priority is the normalization of the volemia and the normalization of the blood pressure. You understand? And that's why this is the priority. And this was also a topic tested in Nclex, is something that is in the Nclex test plan. You understand? The prioritization of the interventions in Addison disease. Of course, hydrocortisone, parenteral hydrocortisone is very important, but will take a little more to start working. Makes sense that the priority is the shock. Do you understand me? So the shock, the management of the shock, which is basically a form of hypovolemic shock, is the priority, is the replacement of the volemia. So the isotonic fluid, in this case, the normal saline, is the priority. Something similar, we studied that in, ¿cómo se llama esto? In diabetic ketoacidosis, you remember? Do you remember that the normal saline was more important than the insulin? Or not remember? Guys, please interact with me. Say yes, no. You're
Yes,
crazy,
yes,
Professor
Professor.
McGee. You're crazy. You're senile. Okay. You need to interact. You say yes. We remember. So if you have a question in which what is the priority of what is the priority in diabetic ketoacidosis, yes, it's true. The insulin, IV insulin is a priority, but it's first is the management of the hypovolemia, because what is killing the client with acute decompensation of diabetes is not the hyperglycemia, it's the hypovolemia that the patient has a consequence of the osmotic diuresis. Of course, the origin is the hyperglycemia, but the hyperglycemia can wait to be treated. The priority is the replacement of the volemia. Are we good? Okay, that's interesting. Very good. The next question to practice. The nurse is assessing a 30-week gestation female client going for amniocentesis. Okay, 30 weeks amniocentesis. Okay, why do you think an amniocentesis could be done at 30-week gestation? Why this woman is having an amniocentesis at this level of the pregnancy?
Because the fetus has to be developed at a certain rate at this time in order to be able to diagnose, certain.
Let me work with that, because I think that you have the right idea, because at least you didn't say malformation, okay? But you have the right idea. So usually we evaluate the growth and the evolution of the fetus without a need of amniocentesis, usually with the ultrasound, and even with the measurement of the, how do you call that, the uterus height. Okay? The uterus height, okay, we can have an idea of the growth and evolution of the growth of the fetus. And of course, the ultrasound is very useful, which are non-invasive. But sometimes amniocentesis, which is an invasive procedure, must be done at this time, and is to evaluate the fetal wellness in case of diseases. Could be, for example, a mother that is having a preeclampsia or has diabetes, or a mother that is having a situation that is incompatibility of the blood groups, etc. In general, at this level of the pregnancy, the main reason for having an amniocentesis is to determine if the baby is already ready to go out before time. Sometimes in pregnancy, babies must be taken out before waiting to the completion of the pregnancy. Why? Because there is a condition in the mother that is harming the baby. We mentioned before diabetes, preeclampsia, etc., etc., etc. Yes, but we must know that if the baby is ready to breathe out of the uterus, and we need to determine for long maturity. And then this amniocentesis, the main reason for doing this amniocentesis at this level of the pregnancy is to evaluate for long baby's long maturity, to see if the lungs are mature enough as to having possibility of surviving out of the uterus. Guys, in a woman with this kind of diseases, the baby is better in an incubator in the NICU than in the uterus, okay? Because the uterus is hostile for the baby. That's why it makes sense taking baby out at 30 weeks of gestation if the mother has a very severe condition that is harming the baby. But we need to be sure that the baby can breathe, okay? And you know that the maturity can be induced artificially with steroids, glucocorticoids administered to the mother. And they do some tests in the amniotic fluid, the lecithin and sphingomyelin index, to see if the lungs are mature. But you answer what I wanted you to be answered, because the majority of you commit a mistake, and it has been tested, that at 30 weeks gestation, the purpose of the amniocentesis is to diagnose malformations or chromosomic disease. No, guys, this needs to be done earlier. You need to do these tests earlier, before the 18, 20 weeks. Why? Because the amniocentesis that is diagnosing a chromosomic or genetic, okay, severe condition, okay, need to be done in a moment in which interruption of the pregnancy is possible. It makes, logic. And now, with more reason, you are aware of the polemic that the country is living in this moment in relation with this detail, yes? And with more reason, you need to understand that if there is there a justification for interruption of the pregnancy that could be diagnosed with amniocentesis, should be done early enough, okay? Before, at least understand before the 20th week of gestation, and maybe earlier. So this you answered what I wanted to be answered, okay? And this is why I saw that. Why I saw that. It was a question. Was a question of, oh my goodness, let me try to remember. It was a question in which what the nurse will say to the parents of a pregnancy child, okay, that has high risk of having a hereditary or chromosomical severe problems. But the parents express that for religious reason, for religion, okay, they don't accept abortion. They don't accept interruption of the pregnancy. So the right answer of this statement was, well, then it doesn't make sense to make, okay, a amniocentesis to diagnose this kind of chromosomal abnormality, because if there is no possibility of interruption of the pregnancy, it doesn't make sense, okay, to have this procedure as an invasive procedure. So you need to understand why amniocentesis are done. That's the purpose of the discussion that I brought. Okay. So let's go back to the question, because the question was not about this. The woman is going to have an amniocentesis for any reason at 30 weeks of gestation. Which of the following question has priority at this moment? What is the most important question the nurse who asks a woman that is admitted to go for a amniocentesis? Of these four.
When did you have your last meal?
When did you have the last meal? Okay. What kind of anesthesia is used for amniocentesis? General, if it's needed sedation, it is
Local
local.
anesthesia.
Huh?
Local anesthesia.
Is local anesthesia. Is a local anesthesia. Is a procedure that doesn't require sedation. Is an ambulatory procedure. Is not doesn't require sedation. Yes, and it doesn't require general anesthesia. It's local anesthesia.
For me, it's B.
It's B as in boy.
And why B as in boy?
Because maybe she has RH negative.
Yes.
Yes, and
Negative
for the Rogan.
RH. Okay.
Yes.
And what happens if she is RH negative, or
She
maybe if
needs
she's
Rogan.
O? Okay, so it's going to require a Rogan, because Rogan is given to any RH negative woman, and Coombs negative, okay? Need to be also Coombs negative, okay? Coombs negative, okay? Is given usually in the middle of the pregnancy, around the 24th week of gestation, around this, and then at birth, no? Within the 72-hour birth, yes? This is the two doses that most receive any RH negative, Coombs negative woman. But if there is any invasive procedure or trauma, accidental trauma or violent trauma, sometimes there is a violence, okay, domestic violence and this kind of horrible stuff that I hate to talk about, okay, then an extra dose of Rogan must be given. So if this woman receives the Rogan, is RH negative, okay, suppose that is RH negative, receive the Rogan in week 24. Now need to receive in this week 30th, okay, during the procedure, another dose. And again, another dose when the baby is born. Remember, the purpose of the Rogan is to prevent the mother to be sensitized, to be vaccinated by the possible RH positive red blood cell that the baby could have. Yes? So the most important is to determine if the woman is RH negative. It is the most important. is the most important, because then we need to anticipate that an extra dose of Rogan must be given. So there is no need of absolute NPO for amniocentesis. They don't require NPO for amniocentesis. The risk of vomiting and aspiration is very low. Of course, they recommend a light meal, okay, 6 hours, okay, before, until 6 hours before, and to to drink clear liquids since then, okay. But there is not a need of being in absolute NPO. Very different if it is, for example, a curettage, if it is, let me help you guys, it is an endoscopy. So procedures in which sedation or general anesthesia is provided, or procedures in which the stomach is going to be explored and must be empty, okay? In which, of course, is important. It could be a very important question.
Professor, one question.
Sure.
Always she is pregnant, has to receive the Rogan after that?
Can you repeat? Always?
The lady has to receive the Rogan?
If she is Rh negative and couldn't negative, must receive Rogan.
Okay,
in the
Professor.
middle of the pregnancy, around week 24. Okay. At the end of the pregnancy, at birth, yes, should be given Rogan to any woman, Rh negative, Coombs negative, should be given a dose of Rogan in the middle of the pregnancy and another dose at the moment of birth.
Professor, my question is about the next time when she is pregnant, she has received always the Rogan?
Each time
Okay, Professor.
a woman is pregnant.
Okay.
Even for abortions, even for miscarriages. Okay?
Okay,
So,
Professor, thank you.
the rationale for this is the following. When a woman is Rh negative, this woman is born without knowing that Rh positive exists. She's negative, okay? She's negative and she doesn't know. But then the first pregnancy that she has could be positive. Okay, positive. She doesn't know that positive exists. And there is a total absolute separation by the placental barrier, okay, separation between the baby's blood and the mother blood. Yes. And she continues being naive or doesn't knowing that positive exists in the world. And for that reason, she does not produce antibodies. You know what is antibodies, no? She doesn't produce antibodies against positive. She does not have antibodies against positive. But if any trauma occurs that could disrupt a little teeny blood vessel there in the placenta, a little rupture of a teeny microscopic blood pressure in the placenta, then only one positive red blood cell can enter in the mother's circulation. And this is like a vaccine, like today I got my flu shot today. So it's like my today's flu shot. In my body entered the antigen of the virus of the flu. It's like, an antigen, the positive red blood cells. And then she said, what is that? The immune system says, what is that? This is something that I don't know. It's something that doesn't belong to me. Let me start producing antibodies against this stuff because this is not mine. But those antibodies can cross, the blood placental barrier, yeah, and can harm the baby. The first baby won't be harmed generally. Why? Because this trauma is not usual. Yes, it's not usual. The trauma tends to occur when the baby is born. In the moment that the baby is born, the baby is out, yeah? And the placenta detaches is in the moment in which trauma occurs here in the uterus, and is the first moment in which those positive red blood cells tend to enter into mom blood. So it's the first baby, the first pregnancy, the one that produced the vaccination, the sensitization of the immune system of the mother against the positive red blood cells. Even if it is a miscarriage, even if it is an abortion, if there is a term pregnancy, the baby's out and the baby has no problem, yeah? But the blood of the baby passed to the mother in the moment of birth, and now, since this moment, after delivering the baby, the mother will start producing antibodies. Of course, the baby is outside, so blah, blah, I'm outside, no problem, okay? You're not going to harm me. But then the next baby that is going to be in this uterus, the next one, the second pregnancy, is going to be harmed by the antibodies that the woman is already producing. So what is the role of this Rogan? The Rogan is hiding any red blood cell, positive red blood cell that could pass to the maternal circulation. So why they give that in the middle of the pregnancy, just in case? And why they give that at the moment of birth? Because we are sure that at the moment of birth, when the placenta detaches, there is going to be a little exchange of the maternal and fetal blood. In this moment, if the fetus is positive, and we don't know what is the fetus, we assume that always that is positive, the mother will be sensitized. What is the role of the Rogan? Hide this. But if the woman is having an accident, she fell and have abdominal trauma, because I saw this question in English about a woman Rh negative, pregnant, and had domestic violence, and she was beaten by the husband. What you need to care, especially in this case, what is special to care in this patient, a part of the routine of domestic violence and etc. Okay, give a plan to give an extra dose of Rogan to this mother, because in this trauma, some red blood cells could pass to the woman. Why I'm mentioning the word Coombs? Coombs is a blood test. Coombs is a blood test that determines if the woman has or not antibodies against positive. So if the woman is Rh negative, should be also tested for Coombs. The Coombs must be negative. What means that she is still not knowing. She is still naive and is worthy to give the Rogan, to keep her naive, to keep her not knowing that positive red blood cells exist and prevent the formation of antibodies. You understand? Oh, what happens if the woman is Rh negative and the Coombs is positive? Sadly, in the first pregnancy, somebody forgot to give the Rogan, and she already knows. She is already producing antibodies. So there is no sense. There is no sense in giving. There is not sense in giving the Rogan to this woman. So that's why I say Rogan is given to the woman that is Rh negative and Coombs negative. So she is still naive. Did I explain myself? Do you understand what I explained? The rationale for the Rogan, why it need to be given?
Yes, Professor.
Yes,
Okay.
Professor.
Yes.
Yes.
It's important that you understand why. You don't memorize. No, it's giving at the beginning of the pregnancy, it's giving at the birth, and it's giving in any trauma or in invasive procedure. No, you need to know why. And now, if they change the question, you can't find the answer. Yes. So I agree with you. Okay, that's it.
Sí, pero, bro, una pregunta.
Yes, go ahead.
When you give it at the birth, you give it right when the client is giving birth, or you wait the 72
Okay,
hours?
remember, I'm not an expert in that, but the book says, the protocol says within, given within in el intervalo, within the 72 hours of the birth is okay. So
And then
within. Okay.
with the violence, the extra dose is given when?
Immediately. And the same within the 72 hours, but as soon as
Okay.
possible.
Thank you.
Okay. Very good.
Professor, whenever you said there is a violence, it is given because the lady lost those.
Remember, in the violence, a little blood vessel could be broken in the placenta because the placenta has the baby's blood. And here are the blood vessels of the mother. They are separated by the barrier. But then, if there is violence, a little microscopic breakage could occur there, and now the baby's red blood cell can pass to the mother. And it's like a vaccine, you understand?
Okay, perfect. Thank
It's
you.
clear now, no? Okay, good. A good discussion. A good discussion. So that's the story of the RH. Mm-hmm.
Professor,
Yes.
why is performed the amniocentesis after at 30 week gestation?
In this case, I assume that for A, B, or C reason, they want to know if the baby's lungs are mature enough as to be, induce the birth or having a C-section, because something's happening in the mother that is not convenient for the baby. So that's why doctor could decide to take the baby out before time. Because the mother can be having a decompensated diabetes, there is evidence of fetal distress. You know that at this period is when they start doing the non-stress test to see how's the baby. Maybe they notice that the baby is having a non-reactive, non-stress test, and then they do a biophysical profile at this time of the gestation, and maybe the biophysical profile say there is a severe placental insufficiency, and the baby is at risk of sudden death in uterus and having a stillbirth. Okay, for my people that don't speak English like me, stillbirth, okay, is another stuff that I'm teaching, because one of my students told me that he had in his English this word and he didn't know what it meant. Is when a baby is dying when the baby is already big enough after 20th week of gestation, when could already be surviving outside the uterus, but dies in the uterus and is born dead, is called stillbirth. Okay, so those are the reason for doing amniocentesis at the end, is just seeing for the wellness of the baby. For example,
Thank you.
when you have a case, suppose that I have a woman that is coming from Venezuela, and she has her second pregnancy. It's gestation 2 para 1, okay? Gestation 2 para 1, yes? And and she is Rh negative, okay? Rh negative. And you ask her, ¿cómo se llama? Did you receive the Rogan in your first pregnancy? And she says, I don't remember, because I received a lot of shots, okay, in my first pregnancy. And then what you need to do, you need to do the CUMS. If exactly, you did the CUMS, okay, the CUMS in the blood. If the CUMS is negative, okay, probably she received the Rogan, and then she's still naive, yes? But if she's CUMS positive, what we do? Okay?
No ponérsela.
No, we don't. But what we do with the second baby? We need to take care of this baby. Okay, so we need to take care of this baby. So now the perinatologist, which is the doctor that deals with this kind of situation, is going to be monitoring what is doing this woman to this baby that is growing there inside the uterus. Because now we know that the mother is attacking, is harming the baby with her antibodies against the Rh positive red blood cell of the baby, producing hemolysis and anemia. Okay, and you know that this can be mild or severe. So now doctors are going to do periodic amniocentesis. Why? Because they evaluate the amount of bilirubin in the amniotic fluid that is coming from the baby. So the amount of bilirubin that is in the baby as product of this hemolytic disease is going to be expressed in the concentration of bilirubin in the amniotic fluid. And that's why you'll see, for example, that the doctor will be checking the concentration of bilirubin in the amniotic fluid. Because when there is reaches a certain level, then they prefer to take the baby out. Or maybe they decide to do an intrauterus transfusion. You understand? It's an example of why they could be doing, okay, amniocentesis so late in pregnancy. This clarified with this example why they do that. But don't forget that for these chromosomal malformation, trisomy 21st, trisomy 18, that could justify an interruption of the pregnancy, the amniocentesis should be done early. Okay, let's go to this question. The nurse is developing a care plan for a child with cystic fibrosis. Which of the following intervention has the highest priority? Okay, so is this a question of prioritization? Yes, because once they ask, the term is a superlative, the highest, okay, is a prioritization question. What means that maybe all the interventions are correct, but one is more important than the other. Okay, let's see. Provide postural drainage after each meal to improve respiration, consultation with the dietitian to increase calories, proteins, and fat-soluble vitamins, administer pancreolipase with each meal and snack, monitor blood glucose level to determine the presence of endocrine pancreatic insufficiency. Okay, what is your guess?
C as in cat.
C as a cat.
C as in cat.
B as a boy.
And B as in boy. Okay, let's analyze that.
I say A.
And so you can rule out A. Why you rule out A?
After meals.
Because this work should be done before. Okay, all we are clear. If we provide postural drainage after eating, the baby is going to vomit, obviously. Okay, no, before meal. Okay, we rule out that. Is incorrect? We sure rule out that. Let's see. Monitor blood glucose level to determine the presence of endocrine pancreatic insufficiency. Why is this not correct?
Porque eso es característico.
Because it is expected. You want to say that it is expected.
Yes.
Okay, so for your information, it's not expected. For your information, it's not expected. Okay, endocrine pancreas is not affected by cystic fibrosis, only exocrine pancreas. So the pancreas has two functions, endocrine and exocrine. The endocrine is the production of insulin and glucagon that is spilled in the blood. So the pancreas produces insulin and glucagon, and this is going to the blood, and it's called endocrine. This part of the pancreatic function is not affected by the cystic fibrosis. But the other function of the pancreas is the exocrine pancreas. Is a group of enzymes that are produced in the pancreatic juice together with a lot of bicarbonate that are filled in the duodenum, in the small intestine, and are super important for the digestion of the food. You understand? So it is the exocrine pancreas. So yes, we can also rule out the last one because it's nothing to do with endocrine, okay? So it's between B and C. So we are good. We are well oriented in this one. Okay, what is more important? That the baby or the child consumes enough proteins and nutrients, or that the baby can digest those nutrients?
That the baby can
digest
digest.
The baby digests the nutrient.
So because it's important, you can be eating tons of proteins and vitamins and et cetera, of calories. But if you are not digesting those proteins and those calories, those nutrients are going to end in the toilet. You understand? You understand? So you need to decide what is more important, because it's a question of prioritization between two correct interventions. What is highest priority? To increase nutrients or to provide the way of digesting those nutrients, which is the problems in the exocrine pancreatic insufficiency. So now, which one is the agreement? Is it still a discussion between B and C, or is there an agreement?
I think it's C.
Para mí es C, la C.
Sí.
Porque
Yo-
si tú le das
Sí.
todas esas proteínas, esos nutrientes y no lo...
Exactly. So she's
que
saying that
busque.
if those nutrients and proteins are not digested and ends in the toilet, are not going to be, beneficial at all. So the most important is to provide the way of overcoming or bypassing the ¿cómo se llama esto? The how do you call that? Malnutrition, no, is digestion, yes, maldigestion of the food, okay, as a consequence of the exocrine pancreatic insufficiency. And now another detail to memorize, because I have proof that this word is used in English, that the specific name of the enzyme, the artificial enzyme that is provided with the first bite of each meal and snack is called pancreolipase. Pancreolipase. Which makes sense, no? Lipase is one of the enzymes that is produced by the pancreas, and okay, is important. So are we good with that? Is enough with explanation?
Yes, Professor.
Yes.
Yes.
Which one are
Yes,
the
Professor.
fat-soluble vitamins?
A, D, E y K, ¿no?
Yeah, yes.
A, D,
Yes.
E, and
D,
K.
E, and
So
K.
do you realize how important are those vitamins? Do you realize the vitamin K is indispensable for coagulation? Do you realize that vitamin D is indispensable for having normal level of calcium in the blood? Okay. A is indispensable for normal vision, and
can increase the intracranial pressure, right?
well, in overdose,
Sí.
but in overdose, okay? So vitamin A can produce increased intracranial pressure in overdose, okay, in toxicity. Okay? Yes, it can become toxic, but in this case, we are talking about deficiency, because those vitamins are absorbed at the same time that the fats are absorbed. Okay, if we have pancreatic insufficiency, exocrine pancreatic insufficiency, and we have steatorrhea. And what means steatorrhea? We are pooing the fats that we consume. Together with this fat, we are pooing the toilet, the fat-soluble vitamins are not absorbed. And then we are talking about deficiency of fat-soluble vitamins. That's why I say the importance of those vitamins in those. That's why these fat-soluble vitamins are provided. Very good. Is somebody here that doesn't know the other name of the vitamin K?
Fitonadione.
Phytonadione. Okay, if any one of you are not being my student and you don't know that Nclex use this name because it's the other name of the active vitamin K, phyto. What a name, no? Instead of saying vitamin K, that is so easy, okay? They use phytonadione. Okay. Good. Okay. Don't forget that, because I saw that a lot in Nclex. So imagine that you don't know that and you haven't. What is the most important? What is the antidote of overdose of warfarin? And you know it's vitamin K, but you don't see vitamin K all over in the question. Instead, phytonadione. What is that? Okay. So it's important that you know that, just in case you don't. Okay. I'm trying to help you to overcome the little difficulties that I've seen before with other students taking their English. Okay. Let's see this. The nurse observed jitteriness in a newborn weighing 9.2 pounds. How is this weight?
Overweight.
Overweight is good. Okay.
En
Unless it is, ¿cómo se llama? The basketball player, the big one, the one that lives near my. It's a macrosonic, yes, it's a macrosonic. Okay, unless is this guy. Okay, okay, it is a macrosonic baby. So anything above 9 pounds is a macrosonic. And what is the most common cause of macrosonic babies?
Diabetes.
Uncontrolled maternal diabetes. Uncontrolled or not well controlled maternal diabetes. Okay, so we need to suspect that this baby could be, okay, a child of a diabetic woman. The capillary blood sugar is 36 milligrams. Which of the following interventions are appropriate to let over apply? Let's see, one by one, yes or no, true or false, okay? Bring the infant to the mother for breastfeeding. Yes or no?
Yes.
Yes, is the preferred method. Keep the infant NPO because of risk of aspiration?
No.
Administer IV dextrose if glucose persists low after breastfeeding?
Yes.
Okay, it is something that I could make a quotation
Yes,
mark because the
sure.
protocol say that you repeat the capillary blood sugar after breastfeeding is still low, you take again the shot for breastfeeding. Of course, if you have less than 30 milligrams, okay, or you see the baby having lethargy that cannot breastfeed, or the baby having seizures like rolling the eyes, then in this case, of course, is when the IV dextrose is indicated. What I read, guys, this is not my expertise, pediatrics, but what I studied about the protocol in hypoglycemia is that any baby having less than 40, the indication is feeding, preferably breastfeeding. And if the IV dextrose is only given when it's below 30 and the baby is lethargic and all the stuff that I mentioned before. This is as far as I remember the protocol for management of the stuff. But in reality, if I were having this option, I would be with a lot of doubts in my ankles. With a lot of doubt. And this is what I do in those cases, put the quotation. Monitor hourly capillary blood sugar until normalization. Yes or no?
Yes.
Of course that yes, makes sense. Provide formula instead of breast milk if the diabetic mother receives insulin.
No.
Are you sure?
Yes.
Is not this insulin producing more hypoglycemia?
No.
Okay, I want that.
No.
No. Don't say that, Professor. You are confusing me. No. ¿Cómo se llama? Insulin is not passing to the breast milk. Okay, so it's not passing to the breast milk, and the diabetic mother receiving insulin can breastfeed. The only precaution for the woman is to take a snack before breastfeeding, because breastfeeding lowers the blood sugar, and the mother can have a hypoglycemia, okay, when breastfeeding. It's the only precaution for the mother, not for the baby. So there is no reason for that. So this is definitely no. And I'm still having doubt about this sequence. Guys, remember that what I try to reproduce here in those practices is what is going to happen in our Nclex. We are not going to be sure of all the questions, but we don't need to know everything. We don't need to get 100 in English to pass the English. So this is a situation that can repeat in your English, okay? Can repeat in your English, okay? Because it is a problem of wording here. they don't say how many breastfeeding. So maybe it's acceptable to give IV dextrose if the glucose persists low after breastfeeding and breastfeeding again. Okay, so maybe the baby is breastfed and the blood glucose continues dropping, and it's a possibility. So I have doubts in this option. So I would probably be in my anchorage expending a lot of time considering this out. It is very easily this rule out. It is very easily ruled out. Those two are very easily accepted. But then I am not sure that it was exactly would be the wording in an anchorage question. Maybe this question is not well worded, but the protocol says that if the blood sugar persists low, but the baby is active, okay, provide more breastfeeding. But if the baby is not improving, administer IV glucose. So probably at the end, I say it's overthinking. Let me mark this as correct. This is probably what I would be doing at the end. I don't know what you will be doing, okay? Because of course, each one of us is going to be taking the NCLEX alone, but it could be more or less the way of dealing with this question. Any suggestion, any discussion, any suggestions? No? We move?
No,
Okay. We don't need to have 100, okay? And of course, we need to know how to identify clients. We need to avoid being killing people. But failing this question is not going to be something determining. Okay. So this is just to give you the confidence that if you are not sure in this question, it shouldn't produce let me think how to say anxiety or depression at the moment of taking the test. Okay, take a decision, mark or doesn't mark or don't mark this option, and submit and move on. Move on and do your best in the next question. That's what I'm trying to say. The fact that you fail some question doesn't mean that you're going to fail the test. Okay, so don't stop fighting. Okay. Okay, let's continue. Which assessment finding the nurse expects to see in an infant with acute otitis media? Hello, that apply. Okay,
Professor, I have a question on the last question.
Okay, go ahead.
I'm sorry, I got disconnected, and I had to connect back again. On that question, what would be the answer? A?
We were discussing that A and D without doubt were correct. That B was incorrect. E was incorrect. So cancel those and pass to the mother. But we were having doubt with C because one option, if the baby is still having low blood sugar, is providing more breastfeeding. But we were discussing that also the protocol says the baby is lethargic, is not able to breastfeed, the baby is a very severe hypoglycemia, less than 30. IV dextrose is indicated. So we were having doubts. And we were discussing here that these doubts are healthy and that if we have this situation in our ankle, we should not freak out and we take the decision. So I took my decision was to mark that, but it doesn't mean that I'm sure that this is a right answer. I'm not sure. I do a lot of confusion. I'm just commenting that we were commenting, discussing here, that this is going to be a feeling that is going to be very common during your anchors, and it doesn't mean that you're going to fail your anchors, and you need to decide, submit, and move to the next question and fight in the next question as all the questions have been already answered correctly. This is what we commented and discussed, and we agreed while you were disconnected. Which assessment finding the nurse expect to see in an infant with acute otitis media? Fill out that outline. Okay, pulling of ear. The child is pulling the ear if the child, the infant is having, okay, acute otitis media? Who have read or hear about that or heard about that?
No.
Pulling,
No.
no, depende de la edad.
¿Qué es pulling? ¿Qué es?
Jalar la oreja.
Jalar la oreja. No, I
It's
think
less
no,
than
because
to
the
here
pain.
is
I think no.
pulling down.
I think no.
It's more to here.
Okay, for your information, it's characteristic. They are non-verbal. Yes, infants, non-verbal. Infant until 1 year. Yes, they are non-verbal. They don't express verbally. And then they are going to express non-verbally. So they are going to be crying. They are going to be restless. They are going to be thrashing. They are going to be rubbing the ear against the mattress, and they're going to be pulling the ear. So you need to be able to identify when a baby is hungry, for example. You don't say, I'm hungry, I'm hungry. No, they start, crying, or they are going to be sucking the fist, etc., etc. The same way, you need to identify the nonverbal, communication that they have and will have pain. And in this case, otitis media is common more common in little children. So you need to identify that it is characteristically described in all the books, because it looks that is a very constant finding in small children with earache. Are we good? Restlessness?
Yes,
Restlessness, yes or no?
Yes.
We said
Yes.
that, of course.
Yes.
Inconsolable crying?
Yes.
Yes.
Yes, it hurts. Discharge from the ear. Okay, you see discharge coming from the ear.
Yo creo que sí.
Why you think, you believe that yes?
Infección.
Okay. So let me try to draw, okay, the middle ear. Just taking two, and here we have the ¿cómo se llama? The eardrum, okay, the eardrum, the tympanic membrane, okay, the eardrum, okay. Where is the ¿cómo se llama? The otitis media, here or here? So 1 or 2. What is otitis media?
2.
In 2, this is Otitis Externa. Okay, let me make it a little more scientific. Okay, let me be a little more scientific. Okay, let me see the anatomy of the ear. Okay, image, because my drawing was miserable, and ear, okay, ear anatomy. Okay, so let's see a good one. Okay, a good one could be this. Okay, a good one could be this. Okay, so we have, this is the external canal, and here we have otitis externa. Otitis externa. Okay, when there isn't this stuff. This is also called swimmer ear, because frequently is found in swimmers. When water enters here, can produce an infection of external ear. Okay, and then you have earache, and you have some kind of debris and suppuration. When there is otitis media, is here in this chamber here that is behind the eardrum. Okay, it's behind the eardrum, and the inflammation can produce the accumulation of fluids here. Those fluids can be clear like a serum, and then they call it otitis media serosa, or can be pus, and it's called suppurative or purulent, not pus, suppurative or purulent otitis media. When there is too much liquid here en esta cara, yo no puedo dibujar aquí, allí. When there's too much liquid here in this cavity, when it's too much liquid, then they make pressure in the eardrum, and then you see the eardrum bulging. Okay, let me now show you bulging eardrum. Okay, so let me see a normal eardrum. Okay. You should show for the normal. I think it's the normal eardrum. Okay, but look at this eardrum. Do you see that this eardrum is bulging? It's pushed from something that is inside. Yes. And then there is a moment in which this is going to burst, and then perforation will occur. So now, when the perforation, the pain is terrible. I remember that I suffered of this when I was a little kid. I'm talking 1950, 1954, 1955. And I remember that my parents took me to several times because they travel a lot in an airplane. And those times the airplanes didn't have this pressurized, cabin that we have now. So when the airplanes took off, then you felt the pressure in the ear, and I remember that I suffered a lot of earache. Horrible. Until what? Until this burst. When the eardrum bursts, the perforation occurs, then the fluid is coming out. So now you have secretion of fluid, coming out. And there is an immediate relief of the pain. Immediate relief of the pain. What doctors do to prevent them from happening? So before the perforation, the bursting of the eardrum occurs, they make a little incision with a scalpel in the part of the eardrums that is easier to heal later, and they introduce this tube that stays there for a long time. This tube allows the liquid to live. So now it's a question: in which position you place the shot immediately after this tympanoplasty is the name of this procedure, in which these eardrum tubes or aeration tubes are placed, and you put the shot with this affected eye down, for what? To promote the drainage of the fluid. Of course, if you put this ear down, the fluid will come out through this tube. Make sense? Those tubes are left there until all the process is healed. The only precaution is to prevent the child from diving, from sinking the head under the water, and preferably using those ear plugs, when enjoying the swimming pool. That's it. And those tubes are coming out spontaneously. One of the questions that we could have is why some children have recurrent or repetitive on otitis media. Somebody knows the answer to this question?
Tabaco.
Yes, one of the number one risk factor is somebody smoked at home.
Smoke.
It is said by statistics. Even if the person takes the care of smoking out of the house, even in those cases, there is demonstrated statistically an increment of the incidence of otitis media. So this is going to be marked as an option if you have this question. The other reason is when the baby is taking bottle in prone position. Sometimes when they are bigger, they can hold the bottle, and we prop the bottle so they can take the milk or the whatever, while on the crib. Yes, this is another reason for that. So they should be fed in vertical position. And of course, that's the reason for which breastfeeding is protective against, okay, down the otitis media, because you need to breastfeed with the baby in upright position, no, totally horizontal. This is another reason for this recurrence. It's a common question in your English. What you teach the parents of a child that is having recurrent affected, you know that. So this is the otitis media. And yes, you can have, okay, a secretion of pus, okay, purulent secretion. Okay, I was looking for this. You can have purulent secretion coming out, when there is perforation of the tympanic membranes. And incredibly, when this happens, the baby feels much better, okay, because now it's draining, okay, it is draining, okay, so it can see that. Are we good? We learned with that? Okay. So let's close here. And close here. Remember that this is the Eustachian tube. It's not so big like this, but it's communicated with the nose. In children, infants, because the anatomy of the head, it is horizontal and short. And for that reason, it's easy for the normal flora of the nose to migrate to the middle ear that is still. So this is the main reason for the source of infection of the otitis media. Good? Okay, great. Go back to our question. Okay, and that's what you didn't understand. Okay, Picasso is nothing compared with me. Okay, so this chart is also possible. And is bulging eardrum possible? Yes or not?
Yes.
Yes.
How lazy you are today. You are lucky that I'm not in present of you in the classroom. Okay, so look at this. All the answers are correct. Is this possible? Yes, it is possible. It is possible. Okay? It is possible. It is possible. The nurse is sitting at the nursing station documenting in the clinical chart of a client when suddenly a code blue is called for one of the assigned clients. What should the nurse do first? Check the client's carotid pulse, initiate chest compression, remove all family and visitor from the room, close the client's chart. What is your answer, guys?
A.
First, do you understand the question?
Z.
Okay. Do you understand the question, guys? So the nurse is sitting at the nurse's station. Sometimes you need to read twice, especially people like me that English is not the first language. So the nurse is trying to visualize the nurse sitting in the nursing station. You know what is a nurse's station, eh? And you are documenting the computer.
Yes.
Yeah.
It's días and
Or a
days.
chart. And
Días and
then
days.
a code is called. And then they are asking you what you do first. So you need to
Cerrar la-
understand that is a chronological priority.
Close the client chart first.
So
Ajá.
everybody understand the meaning of the question.
And then
Yes.
wrong.
Yes. So obviously the right answer, first close the chart, because it takes a second or less than a second. Yes. And then this way you run to help the client that is coding, but you are protecting the privacy of the client that you were working on, because anyone can go there and read it. Okay. The charge nurse of the psychiatric unit is assigning clients. Okay, so it is a psychiatric unit, a cuckoo floor, and the charge nurse is assigning client. Which client could be assigned to a nurse floating from ICU? You know that is a common scenario will be a common scenario in your ankle. You have somebody floating to your service, and you need to know that there are two rules to follow to decide which client should be assigned to the floating nurse. Rule number one, Give an easy client. Don't give the most complicated client. Don't give the most difficult client. And rule number 2, try to give a client that has something to which the floating nurse is familiar to. Okay, something similar to what the floating nurse does in his or her area, in the routine area. So now you have a schizophrenic client talking to an apparent auditory hallucination, client who had a second suicidal attempt the day before, alcoholic client showing diaphoresis, tachypnea, and palpitation, and maniac client with a history of myocardial infarction who is screaming to another client. Which one of these 4 clients is the most appropriate?
C as in cat.
C as in cat.
And what could you have this client that is in C as in cat?
Alcohol withdrawal.
An alcohol withdrawal.
From ICU,
So
she knows
yes,
perfectly.
this is a kind of client that has mainly a physical, okay, a physical distress. Okay, it's not mainly a psychiatric, okay, distress. It's more a physical distress, and it's an acute client that is a high risk, and it's not rare to. Yes.
I have a question.
Sure.
What are the early symptoms of alcohol withdrawal?
Okay, and alcohol withdrawal, one of the first that you're going to notice in the client is restlessness. Okay, the patient becomes very restless, very anxious, very restless and moving, and will have tremor. Those are the earliest manifestations. The patient is restless and is having tremor. When you assess the client, so you are going to see a client that, for example, that is not staying in bed. It's a client that is getting out of bed, and it's a client that maybe is removing catheters, okay, and is very restless, and is having tremor, okay. And then when you assess the client, you will notice tachycardia, okay, tachycardia, and then you notice, okay, the blood pressure will be higher than before. This is the sequence of this. And then this patient is going to evolve, to more serious situation. This is the usual, okay, initial manifestation of the alcohol withdrawal. Anxiety, restlessness, tachycardia, and tremor. Remember that tremor is something that happens when you have the alcohol abstinence.
Okay. ¿Y los late?
Late. Can you repeat that?
Los síntomas tardíos del alcohol.
Oh, late.
Late.
Sorry, mi niña. Acuérdate que yo soy sordo. I'm deaf. Okay? I'm deaf
Mi
and dumb.
inglés que es tan bueno.
No, sí, se me juntaron el hambre con las ganas de comer. Okay. Late is the delirium tremens. The delirium tremens is the late presentation of the alcohol withdrawal. In this situation, the clients start having visual and kinesthetic hallucination. They start seeing bugs crawling the walls and feeling that animals are crawling the skin, and then the patient will start having seizures. So the delirium tremens is mainly characterized by the extreme, severe, late manifestation of alcohol withdrawal, in which the patient is having visual and kinesthetic hallucination and seizures. And of course, the patient is having the same tachycardia, the same hypertension, and fever, hyperthermia, okay, and hyperthermia. And is the level of the stage of the evolution of the alcohol withdrawal in which the client has a very high mortality. The delirium tremens has a very high mortality. I think it's around 30%. You know that those patients must be treated in an ICU, as you mentioned before, and those patients should be treated with benzodiazepines in high doses to inhibit the evolution to delirium tremens and seizures. Don't forget to give thiamine, vitamin B1 to those clients because have thiamine deficiency that could also help in the development of the neurological manifestations, specifically in the Wernicke-Korsakoff encephalopathy. And don't forget that those patients have tendency to have hypoglycemia, low blood sugar. for two reasons. First, because they are alcoholics, and then they have liver disease. Liver is the place where we store glycogen, which is the the storage of glucose from when we are fasting. And ¿cómo se llama? And a part of that, alcohol induces directly hypoglycemia. I think that is the most important to remember about alcoholism and alcohol withdrawal. So summarizing, tremor and restlessness is the earliest manifestation. Then we confirm the presence of tachycardia and hypertension. An activation of the sympathetic nervous system occurs in the earliest stages of alcohol withdrawal. That's why the tachycardia and the hypertension. You see the patient flushed and sweating. And if it is not recognized at this level, then it evolves to delirium tremens with this manifestation. The patient is delirant and with the hallucination, seizures, and death. That's it.
Gracias, profe.
Welcome. Okay, so you are good. You immediately identify this is the right client for this nurse. Okay. Which of the following findings is the earliest manifestation of dehydration in an older adult? Okay, talking about early. Orthostatic hypotension, decreased skin turgor, resting tachycardia, disorientation, and confusion. What do you think?
Diazepam.
Disorientation and
And
confusion.
confusion.
Very good. Very good. Very good. The same happened for infections. Huh?
Yes.
Yes.
Let's move on. Okay, the nurse is assessing a previously healthy client admitted with this skin rash in the torso and intense pain. Which intervention the nurse anticipate in the client plan of care set of that apply? What is this rash? If it is rash in the trunk, is in the torso.
Herpes.
Herpes zoster.
Herpes zoster. Herpes zoster. Also known as shingles. Yeah.
Shingles.
Yes.
Okay. So do you see that it's characterized by blisters?
Yes.
Little blisters filled with liquid over a red or erythematous skin. Do you notice that they are clustered? They are making groups. This is a group, this is another group, this is another group, and clusters. And they are growing over the track or the zone of a superficial cutaneous nerve. Because sometimes they don't put the picture. They describe the lesion with words. Vesicles over red skin, erythematous skin, cluster of vesicles over erythematous skin, appearing along the track or the zone where a cutaneous nerve is. Take care, because sometimes it's not a picture, it is a description. But more frequent in Nclex, as far as have been told to me, is that they have a lot of pictures of herpes. Okay, let's see what interventions are correct, select that apply. First one, place the client in urban and contact precaution. Yes or
yes.
No?
Yes.
No. No,
Bueno,
because
no, porque no
shingles
Don't fight, don't fight. No
is
violence,
contact.
please. No violence, please. Okay, no violence. Okay, don't fight.
Shingle is contact precaution.
Okay,
Si
so
es
we need to
diseminado,
know.
profesor, pero
We need to
Yes.
know there are two types of shingles that we need to know for Nclex. One is the usual, okay, the localized, normal shingles that appears in people that previously suffered of varicella many years ago, probably in their childhood, and then later when they grow older, or for any reason the immunity is decreased, then the patient develops shingles. This common shingle that appears localized is not expelled, the virus is not expelled through the breath, through the mouth. You understand? So only requires contact precaution. Contact precaution. Contact precaution. So if the patient is hospitalized, the patient ideally should be isolated in a room, but it's a room of contact precaution. The door can be left open. Doesn't need to be a negative pressure room. And the only precaution when we enter there, if we are not immune, wearing a gowns and gloves, okay? Contact precaution. But in severely immune suppressed clients, like for example, AIDS, like for example, clients in chemo, like for example, a client with transplants, okay, transplants receiving immunosuppressors. Sorry, in severely immunosuppressed client. These shingles, these localized shingles, can generalize, can disseminate all over the body. You understand? So now the client is going to have lesions all over the body. Which disease reminds you this? When you have those vesicles all over the body.
The varicella.
The varicella. You understand? So now the patient that is immune suppressed, having the generalized disseminated shingles, is having the lesions all over the body, and now it starts expelling the virus in the breath. So is the generalized disseminated shingles the one that requires airborne precaution? Because it's like a second varicella. You understand that? But this is very rare. In all my life, guys, I am old and I saw a lot of patients in my life, okay? I only saw that once in my life. A generalized disseminated herpes zoster in a patient with immune suppression, okay? It's not the frequent. The majority of the shingles are those shingles that you know, okay, that are localized and that are contact precaution, yes, contact precaution. And they don't need to be hospitalized, of course, in this patient. It's just a comment that has been hospitalized because it's in a lot of pain, but doesn't need to be hospitalized and can be, stay at home with, in his or her room, etc., covering the lesion, and that's enough, okay, washing hands, etc. But in the hospital, it must be placed in contact precaution. But if it's a case generalized disseminated herpes zoster, and they need to say generalized or disseminated herpes zoster, then you need to add to the contact precaution, airborne precaution, because the patient starts expelling the virus in the breath and now in the droplets nuclei, and now the virus is floating in the air around the person. You get that? So that's the explanation. Are we good? So now in this case, when they say previously healthy client, obviously is not an immune suppressed client and is having the skin rash in the torso. Torso is the trunk, yes? With an internment and is hospitalized. So the patient needs to be, if he's hospitalized, okay, in the plan of care, we place the client in contact, but don't airborne. So I don't mark this option. Everybody is okay with me? Everybody is no objection? Any discussion? Somebody want to fight with me?
No.
Yes, I have to fight with you, Professor. Okay, I need to take revenge of you because you failed me once. Okay. Second option. Ask for allergy to gabapentin. Makes sense?
Yes.
Yes, professor.
Yes. Why yes?
Porque gabapentin is a medication for the
It's a
pain.
drug of choice for the treatment of the neuropathic pain that produces shingles. Good. Gabapentin is an anti-seizure medication, anti-epileptic medication, but is also used for the treatment of some weird form of pain called neuropathic pain. Pains that are produced by nerves. Like, for example, the nerve that have this inflammation in shingles, which is an intercostal nerve in this case, probably, or the nerve, the facial nerve, no, don't say disparate, the trigeminal nerve that sometimes produce this kind of pain without having shingles. It's a trigeminal neuralgia, no?
Profe, una pregunta.
Yes.
Cuando es con el trigeminal neuralgia, ¿el gabapentin es efectivo o es la otra?
Carbamazepine.
¿Cuál? La
Carbamazepine.
Ajá, sí.
Okay.
En la cara es efectiva el...
Both can be used. Both can be used. But traditional, the experience that the literature has for the trigeminal neuralgia is more with the carbamazepine.
Carbamazepine.
Okay, so you need to know that all carbamazepine is also an anti-seizure, anti-epileptic medication. Okay. Okay, but I just wanted to remember all those neuropathic pain. What about the pain of the patient with the phantom limb pain? It's also neuropathic pain. And those patients also respond to the anti-epileptic medication. The decision of which one to use is going to depend mainly by of the prescriber. So it's beyond our scope. But we need to anticipate that in the management of neuropathic pain, anti-epileptic medication is included. And in this case, it's smart and is okay asking for allergy to gabapentin. So that's the reason for which this answer is correct. Because gabapentin probably is going to be used. Maybe the doctor prefers carbamazepine, so ask for allergy to carbamazepine. Or maybe the doctor is using pregabalin, ask for allergy to pregabalin. Sometimes antidepressants like the amitriptyline are used in those patients, not because they are depressed, it's because also those antidepressants, especially amitriptyline, have been shown in the evidence, in the literature, in the evidence-based practice that are good for the management of neuropathic pain. Neuropathic pains are very weird. And amitriptyline is more used for the neuropathic pain of the diabetic polyneuropathy that brings a lot of pain, especially at night, and responds well to the amitriptyline. Okay, so those are prescriber or provider decisions, but we need to know that those medications are used in the management of pain, but they are not analgesic. They are anti-epileptic or antidepressants. They are adjuvants, are called adjuvants, okay? That is not going to be the English, but was in pharmacology class. Adjuvants, okay, of the treatment of the pain. Anti-epileptic, ¿cómo se llama? Antidepressant, clonidine. Dime tú, clonidine is a medication for blood pressure, but has demonstrated being useful as adjuvant with the analgesic on the treatment of chronic pain. So you need to accept that some medications that are not directly analgesic are used in the treatment of pain. And this is the purpose of this discussion, just to reinforce that. Prioritize pain medication, yes or not?
Yes.
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 Of course. A part of those adjuvants, pain medication, analgesics are going to be given, and the priority here, the priority in this condition is pain. In this condition, the priority is pain. Wash with sterile normal saline and apply triple antibiotic cream.
No.
Antibiotics have nothing to do with this disease, which is viral. And there is no need of using sterile normal saline. Soap and water. Soap and water, a mild soap and water is good to keep it clean. That's it. And anticipate an order for acyclovir.
Yes.
No.
Yes. Yes.
Sí.
Yes. You anticipate doctor could prescribe acyclovir. Acyclovir is an antiviral medication. By the way, when you see a medication that have this syllable, okay, this syllable, okay, vir, suspect is an antiviral. Okay, very useful, okay, detail. Okay, acyclovir is an antiviral medication that is not curing the shingles, is not curing, is not curative of the varicella, but can decrease the severity and shorten the time of the disease. So the use of acyclovir can make this condition less severe and last less time. Make sense? So the same happens with the genital herpes and acyclovir. It's not going to cure, it's not going to eliminate the virus from the body, but it's going to make the outbreak of the disease shorter and less painful or less severe. And let's see the last one. Recommend chickenpox vaccination. Okay, chickenpox vaccination to non-immune clients contact.
Yes. Yes.
Okay, So the answer is yes, because if they are not immune contacts, okay, should be vaccinated because these can produce varicella, chickenpox in non-immune clients. Here is the virus, locals here in this vesicle. And if it passes to a person that is not immune, this person will develop varicella. Can somebody, pass me shingles?
No.
No.
Nobody
¿Cuál
can
fue la
pass
pregunta?
shingles to another.
No.
Okay, the shingles is something private. Okay, if I had varicella in my childhood, or in my case, I had that as a young adult. Okay, new graduated. Okay, a young adult. This virus stays living with me, and if I had shingles in the future, it's this private virus that is living with me since that moment, and will be living with me until I die. He will, or it will die with me. You understand? So nobody can pass shingles to me. This is my virus, my private virus, the one that I got, okay, many years ago. But if somebody has shingles, active lesion, and the virus is there, and somebody that is not immune, do not get in contact with those lesions, this person that is not immune will get varicella, chickenpox, no shingles. Good, very good. Which of the following conditions best requires the continuous care of a multidisciplinary team and a case manager? Okay, so in which of these 4 conditions a multidisciplinary team and a case manager is useful? Sickle cell anemia, left hemiplegia, posterior thrombotic stroke, type 2 diabetes mellitus, appendicitis with peritonitis.
Sí, hacen CAT.
Why?
No.
Why? Okay, it's C as in cat, yes, but I want to know why.
Porque es que
It's
B.
chronic.
For me, it's B.
It's chronic.
B as in boy.
Okay, B as in boy. Okay, what kind of members of the multidisciplinary team that are going to be working with a client that had a thrombotic stroke and
Physical therapy,
physical therapy, occupational therapy.
PT, maybe speech therapy that is part of PT. Speech therapy belongs, it's a subspecialty of this, okay? Muy bien. And it's going to be rehabilitated. It's not going to be forever. It's going to be rehabilitated, let's see, in 3 months. And now, that's it, yes. The rehabilitation stops, yes or not? Tell me, yes or not?
Yes.
Yes, okay. What happens with type 2 diabetes? It's going to be diabetic forever. And it's going to have something new each time, yes? And who needs to see the diabetic client?
Dietitian.
The dietitian,
Yes.
the endocrinologist,
Endocrinology.
the podiatrist,
Yes.
Yes.
the ophthalmologist,
Yes.
Yes.
et cetera, et cetera, et cetera. Yes. So, which one you think is going to require more specialists and somebody, preferably a registered nurse, interacting with all those members of the multidisciplinary team and managing the case? The stroke that was left with a hemiplegia, a stroke already happened and is left with hemiplegia, or the patient that is diabetic? Which one? So now is between which one? These two. Which one do you think is going to need the
B.
B as in boy?
Sí, sí as in cat.
Sí,
Hacen CAT. Para mí la C.
So everybody agrees that it's C as in cat.
yes.
Okay. So what is the characteristic of the disease that requires a case manager? Chronicity is not going to cure, it's not going to stop. And a lot of people must to intervene in the management of the client. Those are the main 2 characteristics of the diseases that requires a case manager and, of course, a multidisciplinary team. The problem with the multidisciplinary team is communication. And this is the main role of the case manager, to be the liaison of that communicates all those members of the team, having, being a patient advocate that is going to promote the continuity of the care, is going to take care of the client, all time, to be sure the client is not abandoning treatment, is not, missing, appointments, etc. So all the stuff. So it is going to be very long, lifelong, intervention. I think of this, obviously, appendicitis and peritonitis, surgeon, nothing, and go home. Sickle cell anemia, the hematologist, and it is a chronic condition, but it's only one member that need to deal with this client, the hematologist. The hematologist. From time to time, they need to make consult with other people, maybe the geneticist to advise the parents. But definitively the one that is going to require a lot of specialists, a lot of people dealing with the client, and for life, for a long time, with a lot of money consumed, because this is going to be very expensive, is the diabetic client. The stroke, after having the stroke and going to rehab for 2-3 months, is going to be the same. It's going to be the same all time. Is nothing new is going to be added. The diabetic client, I think, is the client that fits perfectly in the scope of the needing a case manager.
Profe, una pregunta, please.
Yes.
En stroke, occupational therapy es útil.
Occupational therapies will be useful to rehabilitate, for example, the clients dressing, dressing, eating, etc. So they can help the client to because the client is going to be left with hemiplegia. The hemiplegia is going to stay, won't disappear, can be rehabilitated until a certain level. Maybe it's rehabilitated to the level that the patient can walk. But this hand and this arm is going to be non-functional or minimum functional. And this patient needs to dress and undress. This patient needs to take care of the private stuff like hygiene, etc. And this kind of stuff can be modified, and the occupational therapy can teach the client how to do those ADLs in a different way, including the limitation that have been permanently left by the stroke. For example, if I used to use a shirt with buttons, maybe they are going to recommend to use pullovers, or having a button hook that is a device that allows you to fasten the button in the person that has paralyzed one hand, etc. Yes, it's going to have a case growth. So physical therapists and occupational therapists are going to be the same as speech therapists. But once the patient is taught, once the patient is rehabilitated at the level that is going to be ready, is going home with aspirin the rest of their life. And that's it. The diabetic client is more complex. A client with end-stage renal disease, this is what means those acronyms. In hemodialysis, is receiving epogen alpha 3 times per week, which finding requires the nurse withholding the next dose. White blood cell 14,000, leukocytosis, potassium 5.2, hyperkalemia, hemoglobin 12, absence of bruit and on fistula. Absence of bruit on fistula. What is that? The rationale, the need of withholding the next dose. And
cat.
And why Ciancin cat?
Because when the hemoglobin is in 12, you have to.
Yes. When the hemoglobin is in the range of 11 and 12, the medications will be discontinued. What happens if the hemoglobin starts, increasing, continuous raising to 13, 14? I have 14, and I'm very well. What happens is that happens on them.
Polisistemia.
Trombocitopenia.
No, ningún trombocitopenia.
Trombosis.
The blood
Trombosis.
becomes too hypercoagulable, and then they can have
Polisistemia.
clots. No, well, but it's not as severe as the polycythemia, but in them, the medication, alpha can produce, increased this, viscosity of the blood and thrombosis. And the second that can produce a hypertension. So the two side effects of too much heparin alpha is increased blood pressure and formation of thrombus. That's why when it is around 11 or hematocrit 33, then we contact the doctor because usually it is continue when this level is reached. The other have nothing to do, are not normal, but have nothing to do with the doses of heparin alpha. Which route is used to administer heparin alpha? Routes. Okay. For memorization, is the same as insulin.
Subcutáneo.
Yes, no, no sacudirla, no shake.
Okay, so that's why I'm saying it's saying as insulin. So which routes are used to give insulin? Two routes can be used to give insulin. Sub-Q and
Intravenous.
IV.
IV. The same for this kind of medication. Okay. Where is stored the insulin?
En la nevera, no
In the
refrigerator.
refrigerator. Okay.
Yes.
Can be frozen?
No.
Never frozen. And what care you have when manipulating the insulin vial? Don't
shake.
Don't shake.
Don't shake.
Don't shake. Okay. So that's why in my case, I used to remember the peculiarities of heparin alpha that is tested in Nclex, the care, because it's very, very expensive, the same as the insulin. Okay. And we need to take care of those medications. Okay. Is that taking care, following the chain of cold, So I remember practicing as LPN when I was LPN in a nursing home when the pharmacy arrived with the medication and they left the medication in the nurse's station and I saw that they were leaving the heparin alpha, too long out of the refrigerator. So the nurse was not quick into taking the medication or putting the medication, storing the medication in the refrigerator. And I commented her the importance of taking this care because the medication can be spoiled, can be damaged if it is allowed to warm up. Okay, they bring the medication with those coolers, those pads, those pads that keep the temperature. But if you live there because you are negligent or ignorant, ignorance is bad. Ignorance is bad, and negligence is worse. Okay, but either for negligence or ignorance, and you leave that there, then you can imagine that this medication is going to be damaged, and then it's very expensive, guys. Okay, and at the end, all we pay for everything. See that that all we pay for everything. Okay. Which of the following findings requires immediate intervention in a client with Graves' disease? So Graves' disease is what has Graves' disease? What is this disease for? Hyperthyroidism. Only hyperthyroidism. Only hyperthyroidism is Graves' disease.
Yes.
No. Only hyperthyroidism have also exophthalmos.
Yeah.
And goiter. So this is the triad of Graves' disease. It's not the only cause of hyperthyroidism, but it's the most common and the one that is going for anchors. So let's not make it complicated. But you need to be aware, because it is questioned, that when you have a patient with Graves' disease, you are not only thinking in hyperthyroidism, you are also thinking in exophthalmos. because the care of the hyperthyroidism is one, and the care of the exophthalmos is another. And when the hyperthyroidism is cured, is disappeared by either the radioactive iodine ablation or the surgery, the exophthalmos as a disease persists. And the care needs to be continued. And this detail, if you understand this explanation, is tested. Are we good? That's why I insisted in clarifying the concept of what is Graves' disease. For example, you can have a client with a nodule, a hyperfunctional nodule in the thyroid that produces too much T3 and T4, and this person has also hyperthyroidism, but hasn't exophthalmos. Graves' disease is the one that have hyperthyroidism and exophthalmos. The same autoimmune condition that overstimulates the thyroid gland to hyperfunction is producing the inflammation and swelling of the soft tissues in the orbit that push out the ocular globe. You understand? So you need to have this concept of Graves' disease clear, because then you can have a question related with the exophthalmos. That is frequent. It's frequently tested. If you understand, the exophthalmos is a concomitant disease of the hyperthyroid. Okay, but it's a distraction. Now we know what is Graves' disease. So now they ask, of these four findings in Graves' disease, which one is the priority?
Pilas en K.
Absolutely. What you're thinking?
Thyroid
storm. So one characteristic of the thyroid storm is the appearance of the development of hyperthermia. So any increment in temperature, guys, this question is very repetitive in Nclex. The hyperthermia and Graves' disease as a priority, as an emergency. Because thyroid storm is an emergency. How dies? What is the way of dying for a person with thyroid storm?
¿Cuál es qué?
¿Qué mata? What can kill?
La disritmia.
¿La qué? La arrhythmia. Okay.
She
said dysrhythmia. I agree with you. This is the concept. Dysrhythmia is a cardiac arrest, is a cardiac problem. So what makes the client severely ill, is everything. The fever, the altered mental status, the dehydration, hyperthermia, all this. But what kills the client is the cardiac problem. It produces severe tachydysrhythmias. The most common is atrial fibrillation, but is very fast, and then the patient develops a high cardiac output heart failure that can evolve to cardiogenic shock. Okay, that's why Nclex question: what is the most important medication to give? Yes, the propranolol is the most important medication to give. You remember that we were talking about what is the most important in Addisonian crisis. Now another Nclex question. What is the most important medication, or the first medication to be administered to a person with thyroid storm? And it's the IV intravenous propranolol, which is a beta blocker that prevents the cardiac arrest, prevent the severe cardiac dysrhythmia, prevent the high cardiac output heart failure, and is the priority, and is quickly acting, is immediately acting. As I said, it's available for intravenous administration. Of course, the other interventions that are very important is to lower the temperature with physical methods, because can have rhabdomyolysis. The rhabdomyolysis or myolysis can present in this hyperthermia. And of course, the life support. The anti-thyroid medication, like the methimazole and propylthiouracil, that are medications that decrease the production of thyroid hormone, are very slow acting, very slow acting. That's why, yes, they are important, they're included, but are not a priority. Because since the moment of methimazole or PTU, propylthiouracil, is administered to the client until the outcome, the desired outcome is observed, days will pass. Days will pass. Is the propranolol, the physical method to lower the temperature, and the life support what keeps the client with thyroid storm alive until these anti-thyroid medications start working. Make sense? Okay, it's just to know that. Okay, you know that you have in the opposite condition, in the hypothyroidism, you have another emergency that is the myxedematous coma.
Myxedema.
Yes, the myxedematous coma, in which the patient is hypothermic, but the patient's main problem is that the patient is having breathing problems. Why breathing problem? Because there is a respiratory depression. The brain is so depressed in this hypothyroidism that the respiratory center is not stimulated to breathe. And the patient can have problem of airway and respiration, which is the priority in those patients. Of course, those patients, because they decrease metabolism, they also have hypotension and tachycardia. Perdón, dije un disparate. Hypotension and bradycardia, please. Correct my, I think I'm tired. Hypotension and bradycardia that also requires intervention, and of course the hypothermia, etc., etc. And the most important medication here has been also tested is the administration of IV intravenous levothyroxine. Levothyroxine is rapidly working, especially IV. So that's why this is the life-saving intervention in a myxedematous coma. Okay, the IV levothyroxine. So it's like an exception, no? Because usually the hormones is not the most important medication. It's not the first. In this case, it's the first. Okay, good. Okay, so good explanation. The nurse is preparing the client for insertion of an internal jugular catheter. You know what is the jugular, no? In which of the following position must be placed the clients? So you have A0, B30, C45, and D90. What position is that the adequate for prepare for the doctor comes and get the internal jugular vein?
Flat, no?
30.
No, I think it's flat, no?
So somebody say flat, somebody say 0, somebody is 30. Okay. Why should be placed flat? Even with over elevation of the legs.
Por
Okay.
el, no.
Where is the jugular? Where is the jugular?
Ya.
In the neck. In the neck. Yes.
The neck.
Okay.
No es por el hay embolismo, ¿no?
Have you ever seen your jugular vein? Have you ever seen your own jugular vein in the mirror? No? Rarely.
No, professor, no.
No, it's very rare.
No,
You rarely see your jugular vein. It's very rarely to see that. You know why? Because usually...
I think it's 45.
You say 45, another more.
No, yo creo que es eso.
20.
Another more. Okay, so nobody 90? Nobody 90?
No.
490. Okay.
No.
Okay, let me try to make sense of this.
Bueno, sí, 90.
Oh my goodness. 90 finally. Okay. Okay,
No.
let me make sense of this. Any of you, have you ever seen your jugular vein when you are looking to your neck in the mirror? Or checking the collar of a dress or a collar or something like this? No? Why? Because you are usually seeing yourself in the mirror, okay? You're seeing yourself standing.
Claro, porque está parado.
Standing, the vein is collapsed. You know what is collapsed? Is sunk, is stuck. You know, it's empty. You understand? You understanding me or you not understanding me?
Sí.
If you are in this position and trying to examine clients, you see now the vein can be seen. What means that? How do you think it's going to be easier to take a vein? When the vein is collapsed, is empty, or when the vein is full, is engorged? Yeah? That's why we place a tourniquet in the arm of the client to take a vein, peripheral vein. Makes sense or not?
Yes. Yes.
Okay, so now the logic, the rationale to placing the client flat, even with elevation of the legs, okay? Are you seeing that? Is the purpose is to distend, to engorge, to ingurgitate, is the term, the jugular vein, and being much easier to pierce the vein and introduce a catheter. Make sense?
Sí.
That's it. Convinced? Okay. So here, you can see here the jugular vein. Okay, jugular vein is here, and here's the subclavian.
I'm sorry, Professor. It is flat?
I don't know.
You don't know?
I don't know.
Okay.
Because I wanted to explain why you don't see your jugular vein watching in the mirror, etc., etc. Yes, it's flat, but I just wanted you to be able to answer because you understood my explanation, but I failed. Okay, because I just wanted to convince you what happened when you place a tourniquet and why, because you cannot place a tourniquet in the neck of the client because you go to jail. The alternative is to place the client flat and elevating the legs to displace the blood toward the jugular vein and engorge and distend the vein. This is what I wanted to explain why. So the next time you understand why. Okay, so here's the jugular vein, and this is the subclavian vein anatomically, and don't forget that they join the jugular and continue at the superior vena cava. So anything that the doctor enters in the subclavian vein or in the jugular vein is going to be advanced to the superior vena cava. And they are called central venous access devices. Okay. Central venous access devices can be introduced through the jugular vein or introduced in the subclavia. The catheters introduced through the subclavian last longer and suffer less infection than the ones that are placed in the jugular vein by statistics. Okay, that's why here you see that the doctor preferred enter through the subclavian than through the jugular. But it doesn't mean that the jugular cannot be used, can be used. Which of the following women is at highest risk of ovarian cancer? 16-year-old heavy smoker, 18-year-old with human papilloma virus, 39 years old who has taken oral contraceptive for 19 years, since 20s, and 42-year-old nullipara in treatment for sterility.
B.
B.
A.
As a boy.
A as an apple.
B as in boy, A as an apple.
B as in boy.
D. No sé.
Any other? Okay.
D as in David.
Oh, D as in David. Okay.
D as in cat.
And C as in
No,
cat.
esa-
Okay. Nobody
No,
missed.
es que
Okay.
el
Very good.
contraceptivo es la
Oral
única que no-
contraceptive is good
Es
for
para
Protective.
ovarian
Say,
cancer.
don't say
Okay.
good. They say
it's
protective.
Yes.
And you need to use the adequate, language you need to learn from my English, from my Bostonian English. Okay, mira, let me tell you the following. What has to do age with ovarian cancer?
Mayores de 35, ¿no?
Okay, the older the client, the higher the risk. Obviously, you expect that it's going to be usually is even older than 35. Okay, so first to know about risk of ovarian cancer is a disease of all women. The older the woman, the higher the risk. Okay, so it is an important. Okay. Genetics is important. Okay, genetics is important. Obesity is important. ¿Cómo se llama? Early menarche, late menopause is important. Receiving estrogen as, how do you call that? Estrogen replacement therapy, hormonal replacement therapy. You mean when you get the menopause and you feel very bad, and then you continue taking pills or shots of estrogen is also a risk factor. Of course, smoking is a risk factor for everything. But definitively the human papillomavirus is not a risk factor. For
No,
what?
it's cervical cancer.
It's only for cervical cancer and for neck and head cancer. So mouth cancer, tongue cancer, throat cancer, you know? Okay, head and neck cancer. So, of course, also for anal cancer. Okay, anal cancer, cervical cancer, penis cancer, okay, penis cancer, but neck, oral, neck, and head cancer. So remember, human papillomavirus, cancer in the cervix of the uterus, cancers in the pee of men, cancer in the anus, and cancer in the mouth, throat, tongue, and neck. Are we good? And is a preventable cancer. Avoiding the virus, you prevent those cancers. And there is a vaccine for that. Are we good? Okay, so please have very clear the human papillomavirus stuff, which is a sexually transmitted disease. Smoking is always a risk factor. But what is the problem here?
Muy joven.
Too young. No time to develop a cancer. You know? No time to develop the cancer. So pay attention to the age. They put the age for a reason. So rule out this definitely because it's a mistake, not for ovarian cancer. And it doesn't make sense because it's too young. So now between this, but then you need to know something. Has been established by science, by evidence, and by statistics that the use of oral contraceptive, this pill that comes in blisters of 28 or 30 days, yes, that millions, if not billions, of women in the world are taking to control their fertility, more than not producing this cancer, protection, avoid ovarian cancer. Are we good? So you need to rule out that based in this knowledge that is supported by the science for a long time. Guys, I studied that very young and has been established since a lot of time. Oral contraceptive. Guys, if oral contraceptive produces cancer, do you imagine the demands and the suits that the doctor will have? Because everybody prescribes oral contraceptive. Common sense, critical thinking, yes. So the answer is D. Okay, is D as in diamond. Why? Because it's the oldest. It's the oldest. And you know, as another, pregnancy is protected. Okay, nulliparity or having the first child after 30 is a risk factor. And now is using medication to stimulate the ovulation, and has been demonstrated, especially with clomiphene, that those medications can produce a light increment in the risk of ovarian cancer. So now we have what? The age, nulliparity, and use of medication that have been associated with ovarian cancer. So it has 3 risk factors and is the oldest. But just with the age would be enough to get the right answer of this question. And I'm pretty sure that you are going to remember that the next time. And the person that was confusing human papillomavirus, the risk factor for that, forget that. Remember the risk factor, trying to know where sex is done and will be much more easier for you, okay, to understand that, okay? Very good. Boy with a history of epilepsy is prescribed ketogenic diet. This is true, guys. You know this ketogenic diet that you heard to lose weight, you know, that you eliminate carbohydrate or decrease significantly the carbohydrate and increase fat, good fat and proteins. Ketogenic diet to lose weight, okay, is using epilepsy. Okay, the increment of the concentration of ketone bodies in the blood helps the control of intractable epilepsy. Know that because it's another question in English. The doctor prescribed ketogenic diet to a client. What disease you anticipate the client has? And the answer is uncontrolled epilepsy. Are we good? Everybody understanding? If you don't understand, ask me. Okay, very good. Which of the following menus reflects understanding of the teaching? Ham cubes and potato, chicken and canned asparagus, pork and rice, 2 boiled eggs and buttered biscuit.
Días en boy.
Yes, boy.
Días en diamond.
Can you repeat? I couldn't hear you.
Días en diamond.
Oh, días in that.
B.
Okay. Días in that. Okay. So we're good because what happened with potato, carbohydrate that inhibit ketogenesis. Okay. And rice, carbohydrate that inhibit ketogenesis. The carbohydrate inhibits the ketogenesis. So we need to decide of these 2, which one has the high content of fat and the lower content of carbohydrate. Well, we are good. We are good. We are good. We are good. Okay. We are well oriented. We are well oriented. Okay. We are well oriented. The asparagus are definitively carbohydrates. The biscuit have carbohydrate that have a high content of fat. Eggs definitively is fat and protein. It's very ketogenic. Eggs. Chicken is ketogenic. The eggs are fats in the yolk and proteins in the white. So this is highly ketogenic. Highly ketogenic. Okay, asparagus is not ketogenic. Okay, chicken is ketogenic. This is protein, mainly protein. Okay, so we need to decide. Okay, is butter biscuit that has fat is more ketogenic than the asparagus. My personal decision, if I wear my ankles with this similar question would be D, because for me it has more fat and is more ketogenic. It's more ketogenic. It's going to be more ketone bodies. Remember, the ketone bodies derivate from the fats. So this in diamond for me is more fatty and more ketogenic than B as in boy, because the asparagus. You understand? Asparagus is not fat at all and is mainly carbohydrate. You know, and that's my point of view. I don't know if you agree with me, because if I wear my ankles, I go with B. It has more fat and is more ketogenic.
Professor,
Yes.
But the biscuit is carbohydrate.
Yes,
That's
I
like
know.
bread.
Yes, I know. I understand. Asparagus is carbohydrate and biscuit is carbohydrate, but this carbohydrate has a lot of fat. And I think that is the intention that when I compare. So I agree that between B and C is the answer. But then when I compared, okay, the content of fat, and remember what makes the ketone bodies are the proteins and the fats, but especially the fats. And for that reason, if I need to decide between asparagus and there is biscuit. They both are carbohydrate. Which one have more fat, the asparagus or the biscuit?
The biscuit.
Yeah, that's why this is the rationale for me of preferring this. Okay, but anyway, those are not the kind of questions that I'm 100% sure. But that's the why, because asparagus is not ketogenic, but the border of the biscuit, okay, is ketogenic. And the boils are ketogenic, the same as the chicken. But especially the eggs, because of the boiled eggs. The eggs because have both fats and protein. The fat is in the yolk and the protein in the white. That's why I think that I'd choose this if I were in my ankle. That's my rationale. The nurse is taking care of a client with active tuberculosis after 3 weeks of therapy and 3 negative sputa. Which of the following infection precautions must be maintained to enter the client room? Wear a N95 mask, negative pressure room, use alcohol, hand sanitizer, use gowns and gloves.
A.
That's an apple.
No.
Pero, profe, no te está diciendo que ella tiene 3
Can you say that in English? Can you please say that in English? So it's not only me.
It has
Okay.
3 negative
He-
sputum.
Has
You-
it can
3
go-
negative sputa.
Yes.
Everybody went through the sputa and forgot the
It's
3
a standard
negative.
precaution.
Es standard precaution, yes.
Mhm.
So this is already client going home in standard precautions. And which one is a standard precaution here?
Sí.
Sí.
Okay, so everything in this question is taking care of the details. That is something that you need very careful in NCLEX. That's why I don't want you rushing. And that's why usually I give you at least 2 minutes per question in my test. And I need to fight somebody against the rules because I want you to be careful reading and dedicate time to the details. And in this case, the detail is that I have 3 negative tests, sputum tests. So this client is not contagious anymore and no more isolation is needed. Still is needing 9 to 12 months of treatment, but not in isolation. Why? Because after the initial period of treatment make negative the sputum, the client doesn't need more isolation and is going to become standard precaution as you and I. So is the regular. So the only standard precaution here is C. Okay, the last guy. The nurse is checking the prescriber orders for a client with acute thrombotic stroke. Okay, so a patient is having in this moment a stroke in this moment. Which of the following orders requires clarification? And now we have carvedilol, which is a beta blocker. This is the regular dose. By the way, carvedilol comes in tablet with very weird presentation. 6.250, 3.125, very weird. It's the only medication that I know that comes in so weird presentation. But this use is used for blood pressure and cardioprotector, etc. Aspirin, 81 milligrams daily. D5-WIB, 110 milliliters per hour. Clopidogrel, which is, it's Plavix, is also antiplatelet, 75 milligrams PO daily is the correct dose. What is the order that you object?
Sí, Hassan baby.
Okay, a beta blocker. But somebody today talked me about in the first question that we practiced today, somebody, or maybe this person already left the meeting. Somebody talked me about the hypotonic solutions. Nobody remember that somebody told me I don't like the hypotonic solution because could produce brain edema.
Yes.
Somebody said that today.
Me.
And I fuiste tú, no? And then I say, you know what? When it is a combination of 45 normal saline, no, half normal saline, o sea, sodium chloride 45 plus the 5W in reality is not considered hypotonic because you are adding the osmolarity of the 45 plus the molarity of 5. But in this case, it's pure only the 5W. And you know the 5W is going to be transforming water. It's totally hypotonic. So this patient is receiving a high dose, because 110 milliliters per hour is a high dose, a high volume of liquid, but totally hypotonic because the 5W is totally hypotonic. Yes, because the 5W in the bag, in the bottle, could be considered in this moment, because it is sugar, glucose plus water, because dextrose and glucose is the same, yeah, and water. In this moment could be isotonic, but in the moment that enters in the body of the person, what is going to happen with the glucose? Glucose is uptaken by the cells, or the cells is going to be burned in the mitochondria to produce ATP plus CO2 and water. So the glucose of this solution would be transformed in ATP, CO2, and water. And the water is water. So it's receiving water with water. It's the most hypotonic of all the IV fluids. The 5W is the most hypotonic of all the IV fluids. Hydrating a person with pure only D5, the dextrose in water without sodium chloride is going to induce a hyponatremia and brain edema. So it's very concerning, this indication of only the 5W IV for the hydration of the client. In reality, I don't see the contraindication of using a beta blocker, because maybe the patient has a cardiac problem, maybe the patient has a hypertensive problem, and there's no contraindication to use that. The only contraindication that could see for a beta blocker is asthma. Asthma is a contraindication of using a non-selective, like cardiac beta blocker. Asthma, it is in Nclex. Which one is the contraindication of using beta blocker? Asthma. Why? Because beta blockers are produce bronchoconstriction, and asthma is bronchoconstriction. But I don't see that. Of course, another contraindication of beta blocker is somebody with an AB block with a heart rate of 30. Please, only if your mother-in-law don't allow, beta blocker to be given to this patient. Okay, but in this case, I don't think this is a beta blocker. I think it's the IV fluids. Okay, guys, this is what I have for you today. Any question?
No, Professor, thank you.
No, Professor.
Thank you, Professor.
Thank you, Professor.
Thank you, Professor.
Thank you, Professor.
Thank you for your attention and for your good moment, and see you next time.
Thank you.
Thank you.
Bye-bye. Let me take the attendance.